Good morning. I apologize, we're just going to need one more moment, but we have a lot of people who are joining us live, so I'm just going to improvise for a couple of moments here while we track down a couple of people. For those who don't know me, my name is Sam Guild. I am the president of AMET Melanoma. I am incredibly honored and excited to be here this morning. I've worked with the Cleveland Clinic for many years, and Dr. Truong, who came here about a year ago, asked if we could do an event together. And of course, I could never say no. Nobody could ever say no to Dr. Truong. So I, of course, think she's wonderful as a friend, and as a colleague, I said yes. So I just wanted to go over a couple of logistical things this morning while we wait. So we have, I don't know how many hundreds of people joining us via live stream. So thank you so much wherever you are. I know we often bring in people not just here in the US, but also internationally. This is a disease that impacts everyone globally. So there will be an opportunity to ask questions, so please be sure to keep those in mind. We'll make sure that we can try to get to as many questions as possible. If we're not able to get to your questions today, whether it's on live, you can, please be sure to reach out to AIM. We are very fortunate that we have a physician assistant who works in a melanoma clinic, and we can answer those questions. So thank you so much for joining, and I will introduce Dr. Truong.
Thank you, Sam. We're so glad we could co-host this event together today, and that AIM's own president, Sam Guild, is here with us. It's a really special day. Thank you for coming out on a Saturday. I'm Thach-Giao Truong. I'm the new melanoma program medical director here at Cleveland Clinic. It's really exciting. I came from California last year, and it's just been a really warm welcome. We have a great team here today, and we hope it's informative for you, what we're sharing. It's a very exciting time in the cancer field, and all of you and all of our melanoma community have contributed to that progress. So we hope you take away that positive news and all these advancements that took a whole village and beyond so that we have today. I will have our first speaker, Dr. Gauri Kabor, join us. She is one of our melanoma dermatologists, and she'll share her learnings and teachings with you. Thank you, Dr. Kabor.
Hello, everyone. Good morning. Thank you for coming out here. I'm one of the medical dermatologists here at the Cleveland Clinic. I run the oncodermatology specialty clinic in collaboration with my colleagues at Taussig, taking care of patients who are dealing with cutaneous reactions from their immunotherapy and chemotherapeutic agents. So today we're going to be talking. Oh, sure. Yeah, I can definitely speak up. No problem. Is this better? Okay, excellent. So today I'm going to be reviewing just Skin Cancer 101, what everyone needs to know about screening, prevention, and surveillance moving forward. All right, so what is skin cancer? Skin cancer is an uncontrolled growth of different types of cells in the skin. You're very familiar with some of the more common types, such as basal cell carcinoma, squamous cell carcinoma, and of course melanoma. However, there are also less common types of skin cancers that can occur, which are listed on the slide. But for the purpose of the presentation, we'll kind of focus on ways to kind of monitor for the first three. So what does skin cancer look like, or what should I be looking for on my skin? I usually describe skin cancer in a variety of ways. It can be a pink bump or sore that doesn't go away as expected or is non-healing, a red scaly spot that may be steadily growing in size, and then of course a dark irregular bump that may be growing slowly or rapidly. The main thing to look for is anything that's new, different, changing, and just looks different from the rest of the spots on your skin. Another kind of red flag signs to watch for are if the lesions are bleeding or if they're painful, because really normal skin lesions should not have those symptoms. And one thing you can do to kind of monitor is to check your skin monthly for changes. So who can develop skin cancer? Really anyone could. We have seen skin cancer occur in children, adults of all genders and races, but it is much more common in people of European ancestry for a majority of types of skin cancers. It's very rare in children, and it is much less common in people of like African American, Hispanic, Asian descent, but it can occur. So how common is it? So it is the most common type of cancer in the United States, period. 1 in 5 Americans will likely develop a skin cancer in their lifetime. And approximately 9,500 people in the US are diagnosed with a type of skin cancer every day. So we see a lot of patients for screening for this reason. Of those patients, we expect to diagnose about 100,000 new melanoma cases in 2024 for this year moving forward. So what causes skin cancer? This is kind of a complex question because in addition to significant genetic factors which play a role, the most recognized modifiable risk factor is actually an environmental risk factor, or UV radiation, which is usually in the form of sun exposure or tanning bed use. This is one factor that you yourself can control to minimize your risk of skin cancer, and this can be done through sun protection or other sun protective behaviors. It does not necessarily mean that you need to avoid the sun altogether. So just to discuss about sunscreen, which is the #1 thing I recommend as a dermatologist, for sunscreen, I recommend finding a broad spectrum sunscreen, which should cover both UVA and UVB light. UVB light is the light that is most likely to cause intracellular DNA damage that then leads to skin cancer. But UVA light can also play a role with skin aging and discoloration. We recommend broad spectrum sunscreen to cover for both. We do recommend an SPF of 30 or higher for all sunscreen that you use. This is because the sun protection factor of a 30 means you get about 97% protection against UVB light. When you go up to an SPF of 50, that protection increases to about 98%. So it's not a big jump, so at least a minimum of 30 is recommended. But the biggest mistake I see is that people don't use enough. The recommendation for a full body application is an ounce of sunscreen, which is quite a lot, about a shot glass worth. And then for the face, I usually recommend 2 to 3 finger lengths worth of sunscreen for the entire face and the décolletage region. I do recommend that the sunscreen is water resistant. It's very easy for people to sweat it off when it's hot or if you're out at the pool or swimming. So water resistance is important. Sun protective clothing can also be very helpful, especially if you have a hard time remembering to apply or apply enough. There are brands that make UPF, UV protection factor impregnated clothing, which can provide protection factors of 50 plus, and this can help prevent sun damage to your skin. This is not the same as wearing just regular clothes. If you think about a white t-shirt, that probably gives you a UPF of 3 to 5, so it's not really adequate protection, whereas something that's more opaque with a thicker weave in the fabric will give you more protection. But these brands that make UPF clothing, will have the adequate protection throughout the whole garment. So it's a good way to incorporate this into your wardrobe to provide some sun protection. Reapplication is very important because the sunscreen really only lasts for about an hour and a half to 2 hours. So if you're going to be outside sweating, doing a lot of physical activity, I recommend reapplying. There was a study that did show sunscreen in the blood. This was recognized by the FDA a little while ago, and they are recommending further investigation into 4 sunscreen ingredients that are approved by the FDA to see what the long-term effects of that are on people. But there's no clear evidence that there are any negative effects at this time. We just know that they're present, but we need to do more studies to find out what that effect means. However, we do know that UV exposure does increase your risk for skin cancer, so sunscreen use does prevent skin cancer and your risk for melanoma. So at this point, we still recommend it for a lot of our patients, but we do recognize that more studies are needed to see what these filters actually do in the long term. So what should you expect from your dermatologist when you go in for a skin check? Really a regular full body skin exam is recommended, especially if you have a history of melanoma. We usually recommend skin checks after a new diagnosis of melanoma, almost every 3 to 6 months for several years. And then after a certain time, if we haven't really found anything and we're in a maintenance surveillance phase, we can extend that out. The examination really should involve checking from scalp to feet, and we look everywhere because skin cancer can occur anywhere on the body, including sun-protected sites such as the bottom, the chest, the scalp. Oftentimes, dermatologists will use a dermatoscope, which is the photo here in the slide, which is a magnifying lens. It helps us classify patterns of the lesions so that we can determine if this looks like something benign or something like abnormal that we may need to monitor or biopsy. And now, since we have this tool, a lot of dermatologists have turned to serial monitoring to really track changes over time. Before we used to biopsy everything because we didn't really have a good tool to help us check, is this actually changing? But now we have the technology to monitor things over time, so we can hopefully minimize unnecessary biopsies for patients. So if you have melanoma, what should you be doing proactively? I think regular self-skin exams monthly can be very helpful. There are guides on how to do this. And I think it's helpful to have a photograph taken of your back by a friend or a partner so that you can kind of check things over time and see if there are any changing lesions. But just once a month, looking at your skin closely and seeing if there's any spots that you've noticed changing. Regular skin exams with your dermatologist are recommended, and of course, sun protection. I'm sure you've seen this or heard of this from dermatologists, but this is our guideline on what to watch for on your skin. So the ABCDEs of melanoma is a guide for what you should look for in lesions. So asymmetry is A. So this is if a lesion is not symmetrical. If you take it and try to fold it in half, are the edges matching up? If the borders are uneven, that's something that you should watch for. If there's multiple colors in one lesion, that could be a sign that something is changing. If the lesion is 6 millimeters or more, which is around the size of a pencil eraser, if it's about that size or getting larger, that's another sign to watch for. And then to me, the most important is evolution. Is something changing? Is it changing in size, shape, color, and other traits? This is really the main thing I tell all my patients to watch for, and if you're concerned about it, you can contact your dermatologist to take a closer look. We'll just kind of review some common myths about skin cancer. So a lot of people think you can only get skin cancer in areas where you've gotten sun or sunburn, and this is not necessarily true. While a majority of skin cancers do occur in sun-exposed sites, there was one study that looked at basal cell carcinomas, and they found that about 25% of these cancers occurred in areas that were covered, such as the buttocks, the genital area, the armpits. So there are other factors at play, maybe genetic factors that lead to this. So you can get skin cancer in areas where you haven't gotten a sunburn. Squamous cell carcinomas tend to occur more in sun-exposed areas, but they can occur in other areas, like we see it very commonly in the genital area. And this could be potentially related to an HPV and viral infection. Melanomas can occur in some protected areas as well. I've seen melanomas occur on like the toes, the nails, the scalp, so they can be hidden. And really, you can get melanoma anywhere in the body where there are pigment-producing cells, including the eye, which we have several oncologists who specialize in that. The next myth is, there's nothing genetic about your risk for skin cancer. And this has been mostly disproven. We think actually genetics plays a pretty big role in why some people develop skin cancers and others don't. There are some inherited genetic syndromes that can increase your risk for skin cancer, such as basal cell Nevis syndrome, Lynch syndrome, Cowden syndrome. There's like a whole list up there. Also, if patients have variations in this specific gene called MC1R, this is a pigmentation-related gene. This is what causes people to have like red hair. These patients have increased risk for skin cancers independent of having sunburns. So even just by having that gene, you can have an increased risk. There are some pathogenic alterations in certain genes that are known to cause cancers, such as BRCA1 and 2, and these are commonly known in the breast cancer world, but these genes can sometimes increase risk for basal cell skin cancers and melanomas as well. And then the last one that we've kind of identified over the last several decades is this syndrome called familial atypical multiple mole melanoma syndrome, which is a mouthful, but it's a CDKN2A mutation where patients often have multiple atypical moles. They have several primary cutaneous melanomas, and they can have an increased risk for pancreatic cancer. So there's definitely a genetic component to skin cancer and melanoma in particular. We're still kind of trying to learn more about that and parse out, what kind of stratifies the risk among this patient population. The next myth is people with darker skin can't get skin cancer. And that's not necessarily true either. Skin cancer can occur in individuals with darker skin, all types can, but it tends to be much less frequent and it presents differently. And because of that, these patients, if they do develop skin cancer, often get diagnosed later, and so they're managed a bit differently. We don't really think that there's a big correlation with sun exposure and the risk of skin cancer in skin of color. I think we just don't have enough data to really see if that's a true risk factor for that group of patients. But we do know that a family history of skin cancer, genetics, and a history of atypical moles, and as well as environmental factors, can increase risk for skin cancer in darker skin patients. So I think we have to ask some questions to really stratify the risk. And there's certain ethnic groups that may be more prone. For example, the risk of melanoma in someone of African American descent is about 0.1%, whereas the risk in someone who is Hispanic is about 0.5%. And it's a little bit different. And there's also some subsets of East Asian people who may have higher risks as well. This is just a photo example of one of those melanomas that can occur on the feet, which is a very difficult place to watch for. But this is more commonly seen in African American patients, and it's usually on the nails, hands, and feet. And often the diagnosis is delayed, just given how rare it is. And another fact is about half of melanomas that occur in Black patients are often on the lower extremities, which is different than what we see with our Caucasian patients. So there are some differences there. And then the next myth is if you stop getting sun exposure, you will stop getting skin cancer. And I wish that was the case, but unfortunately it is not. There was a randomized control trial that was done in Australia where they compared people who used sunscreen daily to whatever they wanted. And they did find that there was a significant reduction in the risk of squamous cell carcinoma in these patients who used sunscreen, but it wasn't 100% risk reduction. It was about a 40% risk reduction. So there's likely other factors that play a role in why people get skin cancer later down the line, such as genetics, cumulative sun exposure. If you had very bad burns or blistering burns in your youth, sometimes that can manifest later. And then lastly, once you get one type of skin cancer, that's the only one you will get. And that is also a myth. You can actually have an increased risk of other skin cancers, including melanoma, even if you were previously diagnosed with something like a squamous cell or a basal cell. So this is likely from shared environmental factors and genetic risk factors. So it is critical to kind of look at anything that's changing and really follow those ABCDs and look for things that are painful or bleeding, because those are not normal and those shouldn't be happening on your skin. So to conclude the presentation, skin cancer, including and beyond melanoma, is common. Melanoma is less common, but typically skin cancers can be treated, especially if they're caught early. Sunscreen and sun protection can really help prevent melanoma and other types of skin cancers from developing and reduce your risk overall. However, there are genetic factors which influence the development of skin cancer in general. And regular skin exams with a dermatologist who focuses on skin cancer and melanoma can really help detect these skin cancers early so that we can intervene and hopefully go into a preventative surveillance phase. So thank you so much for listening to my presentation. I'm unable to stay for the panel later, so I'm happy to take questions now if there's any from the audience. Okay, well, thank you so much, and I hope you have a great rest of the symposium here.
Thank you so much, Dr. Kabor. Dr. Kabor actually is really tasked with the next future of teaching physicians too. She's our residency program director, so we're indebted to her for many things. Next, yes. Oh, is this better? Oh, okay, here we go. Next I would like to invite NP Hannah Berg, who works together with Dr. Anthony Tafaro in surgery, so she can share with us some tips on how to get better after surgery. Thank you very much, NP Berg.
All right, can everyone hear me? Any issues? Awesome. So for those of you who don't know me, my name is Hannah. I'm a nurse practitioner here. Some of you had care with Dr. Gassman. I now work with Dr. Tafaro. And my background is plastic surgery, but I specialize in melanoma and do melanoma surgeries with Dr. Tafaro. So my topic today is to discuss, and a lot of you have probably already been through your course of melanoma with us, had surgery already, but this is tips for recovering after surgery. So any people who are watching and haven't had surgery yet, kind of give you the expectations of what that visit's gonna be like. So for your first appointment, and this part to me is so important, the first appointment is a consult. A lot of times we'll have people think that they're coming to us and having surgery at that first appointment. It's a consult. We need to meet with you, review your pathology, get to know you, and start building that trust because we are going to be operating on you. At this appointment, you typically come to us from dermatology with your biopsy already done. So we're going to review that pathology in detail to talk to you about what surgery we're going to offer you. And then we're going to start that process of talking about staging, what's next. And I think one of the most important things just presenting here in front of everyone is everyone has a different journey. They're coming to us at a different point of their diagnoses. So I'm kind of starting this from the beginning. You went to dermatology, you had your biopsy, and now you're meeting us. Okay, so at your first appointment, this is the important piece of paper. This is your pathology report. And this is going to determine the surgery we're going to talk to you about. So breaking this down, there's the tumor type, the Breslow, which is the depth, ulceration, mitotic rate, which is how fast are these cells replicating, and the margins. To keep it simple, the Breslow to us and the margins is very important and is what drives your surgery. So the Breslow is the depth of that tumor. How deep is it going into your skin? This determines if we need to find out, are there lymph nodes involved? Will you have a sentinel lymph node biopsy? And we offer and strongly suggest a sentinel lymph node biopsy for anything greater than 0.8 millimeters or higher. We also look at the margins. You had a biopsy. A lot of times I say a biopsy is just kind of like taking a tip off the iceberg. They're not getting a lot of times all of the cancer. So you do have to have that lesion re-excised. So what surgical procedures are we going to offer you? So most patients are going to get offered the wide local excision, which is the actual surgery part of removing the cancer on your skin. And it's important for us to obtain the correct margin. So for any any Breslow 1 or below, it's a 1 centimeter margin. And then if it's higher than 1, we get 2 centimeter margins in each way. The sentinel lymph node biopsy is us checking to see, has cancer spread to your lymph nodes? So at your day of surgery, your melanoma, so say you have a melanoma on your shoulder, will be injected with a tracer. That tracer starts going into your lymphatic system. You get a quick little scan and it tells us, if cancer were to spread, what lymph nodes would they go to? How does our surgeon know where to look? We then follow that tracer, and then in surgery, we have all the special equipment that tells us which exact lymph nodes to remove and biopsy. There's also something called a lymph node dissection, which isn't necessary for a lot of people. This is where we remove lymph nodes. Oh no, my typo's in here. Lymph nodes where a mass is, or if someone had a positive sentinel lymph node biopsy and they're not responding to treatment, they might qualify for a lymph node dissection. We typically see this in the axillary, neck, and groin. And then reconstruction. So anytime from a surgical point, we're making a hole, we're cutting, we need to know how are we going to close this and make patients happy. Our outcome is we want you to be comfortable with how we closed your surgery. So there's primary closure, skin graft, and then there's a bunch of flaps. The most common one is an adjacent tissue transfer, and then the most complex is a free flap. So before your procedure, you see us. Our surgical scheduler will then call you, get you set up for your surgery, and then pre-anesthesia. Pre-anesthesia is the appointment you need to have to make sure it's safe for you to go to sleep. They're going to review your medications, your lab work. If you have blood thinners, we need to know about that because we need to stop blood thinners, and we need to get clearance from your prescriber. Nothing to eat or drink after midnight, and then please have a ride. If you're going under anesthesia, you need to have someone take you home. After your procedure. So this first one, try your best to rest and relax. We understand you just went through something life-changing, a big procedure, you're uncomfortable, and you're also anxious. And we get that, you're waiting for your pathology results. So I tell people, try your best to take it easy, distract yourself, because the pathology really does take 7 to 10 days to come back. Hopefully, you guys got a nice packet at your discharge that has follow-up instructions and just basic wound care. It's not always perfect, those instructions that you're given after surgery. So if you have any questions, call our office. We're happy to go over that with you. In that first week when you're waiting to come see us for your post-op, if anything is wrong, even if you just want to talk, call us, because that's my job. That's what we're here for. We're here to get you through this healing process, and we want you to know that you're not alone through this. So even if it's something as simple as bruising, let us know, send us pictures, and that's why we're here. Post-op care. So I kind of broke this down into 4 different segments. We have wound care, pain management, monitoring for complications, and JP drain care. So at your first post-op, we'll review your pathology and discuss the plan moving forward. We'll talk about wound care, pain management, and answer all your questions. So for pain management, the first line of defense we tell everyone is, if you're allowed to take Tylenol, we recommend extra strength Tylenol, which is 1,000 milligrams, every 6 hours for pain as needed. You will also be prescribed, unless you told us that you do not want this, a narcotic like oxycodone. And typically that's also to be taken every 6 hours as needed. What I tell patients is stagger it. So say you're having 8 out of 10 pain. Take that oxycodone. 3 hours later, if you're still having pain, take Tylenol. That way you're getting something every 3 hours and you're hopefully more comfortable that way. Another option is ibuprofen. I always tell people ibuprofen is a blood thinner. From my experiences, we tell people you can take ibuprofen and you can start staggering that in as well. Wound care, Aquaphor. That's my favorite thing in the world. So you had surgery. We typically tell people you're okay to shower 24 to 48 hours after surgery. You can get your incisions wet, take off those bandages, unless you have a special bandage called a bolster or a wound vac. We recommend kind of scrubbing around the area and then letting that soapy water trickle down and pat dry. We always tell people baby shampoo or any unscented soap. Typically for the first 7 days, we'll have you apply antibiotic ointment like bacitracin, neosporin. Anything past 7 days, I just don't recommend because you can start getting, the skin can start turning red and doughy and it can almost look infected. So we kind of stop any ointment at 7 days. After those 7 days, you get to start Vaseline or Aquaphor, and hydration is gonna be your best friend. My joke is, I don't know if anyone's seen My Big Fat Greek Wedding, and the girl gets a zit and they say, just spray a little Windex on it to cure the zit. That's Aquaphor for me. When in doubt, put Aquaphor on. A lot of times patients will ask, do I need to keep my incision covered? I say for the first 3 days, yes, because you're probably gonna be having some drainage. But once the drainage stops, it does not need to be covered unless you're doing something active and it can get dirty. And again, your wound care will be based off the surgery you have. Okay, so this is a primary closure. So you can see here, the first picture is they had a melanoma on their back and then they had a sentinel lymph node biopsy. So this is the typical kind of closure. We were able to pull the skin together, and that's called primary closure. The biggest thing, and I think we touched base on it yesterday, is why is your incision so big? You came to us with a lesion or a biopsy site that was the size of a pencil eraser. That all has to do with margins. So, like I said, the margins are gonna be anywhere between 1 to 2 centimeters in all directions. You're gonna have a circle. We then have to turn that into a football shape so that we can close it in a single line. So we tell people that the incision length is gonna be 3 times the size of your, the depth, like the hole that we made with our margins. With closing this, sutures may be absorbable or they may need to be removed. How long the sutures stay in place depends on the location on your body. And then looking at this, I just want to point out, because I'll talk about this a little bit later, you can see there's some redness on these incisions. And a lot of times, a lot of people will think, oh, infection. This redness here is normal redness. You're gonna have redness because of suture irritation. Your skin doesn't like having something irritating it. It's gonna get a little bit red. I'll talk more about what to look for with infection later on. A common complication that I will see is something called a retained suture or suture abscess. So in this picture, you can see those 4 areas of crusting almost. Essentially what this is an absorbable suture that hasn't fully absorbed, and it's migrated its way to the surface. It can be very irritating, little tender to touch. They typically will work its way out and kind of fall out. But what I tell people is if it's bothering you, call us. You can come in, I can remove the suture, and then just put a little bit of antibiotic ointment for about 3 days. We also recommend massage. Massage is key in this whole process of scar healing. Massaging that can help break down that scar tissue. Another complication is a wound dehiscence. So that is a separation of the wound edges. It can be partial or total. So here you can see it's partial, it's not the whole incision. If this happens, please reach out to your team ASAP. It's not an emergency, but it needs to be cleaned. We need to change your wound care, and it will be a wet to dry dressing. And debridement is sometimes needed, but that's pretty extreme. Okay, so one of the most popular types of closures that we use is skin grafting. So this is used in an area where you can't pull the skin together. So think face, feet, sometimes the forearm. And there's two types. There's full thickness, where we take the full thickness of that skin, or split thickness, which is just part of the skin. When you have a skin graft, you're gonna have a bolster dressing or a wound vac for the first 7 to 10 days. While you have that bolster dressing on, that basically is just a rolled up piece of lubricated gauze that's sutured down. I have a picture of it in a second. And you don't really need to do anything, except sometimes we have you put some Vaseline around the edges. Once the bolster comes off and the wound vac comes off, it's all about hydration. So you're either going to apply Adaptic or Zeroform, which is that lubricated gauze, or Vaseline and Aquaphor to the graft and cover it with gauze. Again, keep the wound hydrated. That's keep it simple, hydration. So this is what skin grafts look like. And if you've never had one, it can be kind of scary at first to look at. So the first picture all the way down is a picture of a patient where I just took off his bolster dressing. And it's easy to look at when it's not you, but it does look like a little crater. It's not pretty. The next picture, after doing some wound care, is about 3 weeks later. You can see that it's starting to fill in. I don't have his final picture yet because he's still in the process, but this is all just from keeping the area hydrated and massage. And then this last picture is a skin graft on the scalp. So you can see on the right-hand side, there's normal kind of scarring there. And then there's that little red and yellow area. So the red is something called hypergranulation tissue, which is just overgrowth of the healing tissue. And then that yellow is fibrinous tissue. So if this happens, you see this at home, send us a picture. We'll bring you in, we'll kind of lightly pull off that yellow tissue, and then use some silver nitrate to kind of kick back and slow down the healing in that pinky area. But our goal is to make this look flat. Like, you're gonna have a scar. Anytime we're doing anything, you're gonna have a scar. But by treating it with hydration and massage, it can really start flattening out. So tips for your skin graft, again, hydration. Expect color changes and scabbing. If that happens and you're, in between your appointments and you're worried, reach out to us, take pictures. Pictures mean everything to us, so send them to us on my chart. We'll call you and get back to you if there's something concerning. You can get the graft wet, just be gentle when washing. Some grafts fail, especially on the lower extremities. It's the furthest thing from your heart. So if your graft fails, it's not the end of the world. We'll be disappointed, but you'll heal from the inside out and you'll still heal well. And then when in doubt, send us a picture. So this is an example of a bolster dressing. So bolster dressings are used over the skin graft. Essentially, the purpose is to hold skin grafts in place and prevents fluid accumulation so that your skin graft can fully take. Stays on for about 5 to 7 days. We take it off at your first post-op dressing or first post-op appointment. If you had a skin graft on your leg, sometimes the arm, stomach, you'll get a wound vac, and the purpose is the same thing as the bolster dressing. I will say wound vacs are the things that make our patients the most unhappy because there's lots of beeping, a lot of thing times, you have to charge it, the suction doesn't work, but we give you this nice booklet with numbers to call if that happens. But yes, we take this off at the first post-op as well. And then briefly, rotational flaps, adjacent tissue transfers. This is used when primary closure is not an option and that we don't want to use a skin graft. It's essentially pivoting of the adjacent tissue skin around an axis to close a wound, keeping blood flow. For this, I just want to touch base. The most important thing is monitoring the color of the flap. Make sure it's not turning dusky or gray, because that could indicate that there's not adequate blood flow. The skin should appear normal skin color, but remember, it's post-op, you're gonna have bruising and some redness and swelling. And temperature should be warm like the surrounding skin. So this is an example of a rotational flap. You have the deficit, and then you can see, like, why does he have this big Z scar? It's using all the skin to kind of flap over it, and then this is how he's healing. So it looks really good. Another, I call everybody, this is your little buddy for a while, the Jackson-Pratt drain, or JP drain. So this is used to collect fluid from a surgical wound. You typically will see it in patients who had a sentinel lymph node biopsy or an axillary dissection or groin dissection. This allows the body to heal faster by pulling and collecting all that fluid and not letting it sit in the body. It also helps prevent seroma, which is a fluid accumulation, and infection. These stay in place until the output is less than 30 milliliters in 24 hours. We used to say 3 days, now we do about 1 to 2 days. So expected findings after surgery: mild redness at the incision site, bruising, swelling, small amounts of oozing, and fatigue. When to reach out to us: any signs of infection, fevers, chills, purulent or pus-like drainage, foul odor. If all of a sudden you're having increased drainage, increased pain, if you start developing hardness around the wounds, that could indicate a hematoma or seroma, any redness or warmth, and any color changes to the wounds. If anything is changing and you don't expect this, call us. Like, that is why I'm here. I'm here to be like a resource for you if you just don't know, or you have a question about, is this normal? Infection, these are just some pictures of what infection looks like. We typically will do a wound culture, start you on oral antibiotics, and your wound care may change. A seroma, this is a very common complication with people who had a sentinel lymph node biopsy or the dissection, complete lymph node dissection. It's an abnormal accumulation of serous fluid in dead space. And basically, we disrupted your lymphatic system. That fluid doesn't really know where to go. So sometimes we already put that drain in place to prevent this, but there's other times where we don't. Often the body will reabsorb the fluid on its own. We'll do an ultrasound. Sometimes we try compression, and then we also do aspiration and drainage. And this is a good picture of it. You can see that right there on the side. That is a fluid accumulation called a seroma. Post-op activity: take it easy. Please don't go golfing the next week. Don't lift anything heavy. Like, you just had a big surgery, rest. We tell you not to lift anything greater than 10 pounds for the first 2 weeks. Then start adding in activity gradually. Please, no swimming, hot tubs, baths for at least 4 to 6 weeks. That's sitting in, even if it's your pool, it's still dirty water, and you're just kind of sitting in there, and that's asking for an infection. I tell patients, let's have a diet high in protein and make sure that you're drinking enough water to heal. Lifestyle changes, sun protection. Dermatology just talked about this, but I also tell patients your dermatologist is going to be your best friend. You're going to be seeing them every 3 months for the first 2 years following your diagnosis. After that, every 6 months for 5 years, and then yearly for the rest of your life. All right, and lastly, what are the next steps? You made it through surgery. So these next steps go back to the pathology from your surgery. Your surgical team will follow you until you're healed from surgery. If you don't qualify for medical oncology, we will follow you for about 1 to 2 years post-operatively, and this may include some imaging. Every patient heals differently and has different needs. Our medical oncology team, we all sit right next to each other, so we kind of approach each patient as a multidisciplinary approach. So we'll refer to medical oncology if your pathology from surgery indicates a stage 2B or higher. So if you had a positive lymph node from that lymph node biopsy or anything, if your primary tumor was super, super deep, you're gonna be referred to them. When we refer to oncology, we get the baseline images, which is our CT, chest, abdomen, pelvis, and a brain MRI. And then sometimes we will refer if there's a family history of melanoma too. And then, like I said, dermatology. You're gonna be going to them quite regularly. But I also tell people, if in between those appointments you see something abnormal, you see a skin change, let us know so we can get you in faster for a biopsy, because the patient is the first line of defense. Key takeaway, your pathology determines your surgery. It's completely normal to feel anxious through this whole process, and we're here to guide you and support you in any way that we can. And then, I think you guys know this, hydration is your best friend. Aquaphor and stay hydrated. And just know, we're a great group of providers here, and we care about each and every one of you. So whatever you need, please come to us. We're here to help. That's it.
Thank you, NP Burke. She really does help anytime. She'll find you or anywhere you are in Taussig. Next, I'm delighted to welcome Dr. Lucy Boyce Kennedy. She's part of our medical oncology team and also the director of our pharmacovigilance clinic, meaning this is an initiative here at Cleveland Clinic where we have a dedicated set of physicians who focus on managing side effects from treatment. I was really glad that she had time to come join us. Oh, one more. Very important. So it's that time of the morning where we're going to have a Q&A come up. So if you have any questions so far, please write it on a piece of paper and send it to the sides in a little bit, and we'll address them for you. For those of you who are here live in person, if you're joining us via Zoom, please put your questions in the Q&A. This is a logistic thing. Don't put it in the chat because those actually we don't see. And if you're on social media, put it in comments, okay? We want to hear from you. All right, Dr. Lucy Boyce Kennedy.
Good morning, everyone. So many familiar faces in the audience. Thank you for being here. So the reason I am tasked with giving this talk is because I'm the director of the pharmacovigilance clinic here at Cleveland Clinic, which focuses on helping patients manage side effects from immune therapies and other cancer treatments. So the question I'm trying to answer today is, what should you expect when you're on melanoma immune therapy? So a pretty big change from the topic Hannah was talking about. So taking it all the way from surgery now to whole body or systemic therapies. And I'll say in general, kind of piggybacking off of what Hannah said, if you have a melanoma that's stage 2B or higher, the surgery team will refer you to medical oncology, and immune therapies are IV medicines that are used for stage 2B and higher melanoma. And we'll get a little bit more into that. But when they asked me to talk about this, I decided I would need to start by telling you how the immune system works so that I could then use that to tell you how immune therapy takes advantage of that or manipulates that, so that I could then tell you what the side effects are from there. So this is a very difficult question, I think, to answer in 20 minutes. So I would say for next time, I'd like an 8-hour slot. We'll do the best that I can. So all the figures I use in this presentation today, I took from patient education resources. I downloaded them online for free, and I put the references on the bottoms of the slide and on a reference slide at the end, so you'd have the links. I think they're all good resources if you're looking to read more. So starting out with how the immune system works, the analogy this figure uses is like the art museum where you have a thief that's trying to steal the Mona Lisa. So in the art museum, you have cameras, and the cameras are looking out to see if there's anything suspicious going on. So same with the B cells in your immune system. They're kind of like cameras. They're looking out to see if there's anything suspicious going on in the immune system, and so that, or in the body. So that would be like infections or tumors or anything that shouldn't be there. So then, if they find a thief in the museum trying to run away with the Mona Lisa, then the museum sends the security team to take care of it. In the immune system, that would be like the T cells. So the B cells talk to the T cells. They're like, hey, we have this problem, you need to take care of it. And the T cells will go off and attack the thing that's not supposed to be there. So the T cells will attack the tumor, and the idea is that they would destroy it and get rid of it so the cancer wouldn't grow. And then in the end, in the third panel, you can see the security team has caught the thief, and the Mona Lisa gets returned for many more tourists to enjoy taking selfies with. Same thing in the immune system. So the T cells destroy the tumor, and then the body's returned to like its normal state. So now that we had a fun analogy, we have these really intense immunology figures. So it's one or the other, something everyone can understand, or I'm trying to explain to you these immunology figures, but I'll do my best. So this is how the T cell knows exactly what it needs to attack. The purple hairy thing on the left, that's a dendritic cell. And you see the hairy fingers coming out of it. You can think of them as like, they're kind of sticky. They see the tumor or they see something that shouldn't be there, and they like stick to it and they collect little things off of the surface. So I don't know if I have a pointer, but in the dendritic cell, there's those like green dots in the bottom left. And it's like collected those from the tumor. It then takes the green dots and it displays them to the T cell. The T cell is the big green thing on the right. It displays them to the T cell. So it's like, hey, I picked this up. It shouldn't be there. Can you go attack it? So that's how the T cell knows exactly what it needs to do. So the medications we're going to be talking about for melanoma, they're called checkpoint inhibitors, and that's because they work on something called immune checkpoints. We'll talk about a little what that is on the next slide. But I did want to give you a list of the medications that are FDA approved for melanoma. They fall into different categories. I've listed the categories here, and I would just say the categories, they tell you kind of exactly where in these signaling pathways the specific drug will work. So we have 3 categories. The first one is anti-PD-1 or PD-L1 antibodies. The drugs that fall into that category, I've listed the generic name on the left and the brand name in parentheses on the right, just in case you're more familiar with that. So those are pembrolizumab or Keytruda, nivolumab or Opdivo, and atezolizumab or Tecentriq. We have an anti-CTLA-4 antibody, that's ipilimumab or Yervoy, and you'll usually see that used in combination with nivolumab from the first category. And then finally, we have an anti-LAG3 antibody, that's relatlimab, that's the newest one. And the only way that you'll see that given is in combination with nivolumab. They're in the same bag. And the brand name for the combination of those two is Opdualag. So why are they called checkpoint inhibitors? Or what is an immune checkpoint? So the checkpoints are a system of checks and balances that the immune system basically has built in. And you need these. So the immune system, like literally everything in medicine, and probably a lot of things outside of medicine too, it's like Goldilocks. You need it to be not too hot, not too cold, but just right. So if your immune system is too hot, it never turns off, then your immune system is going to start attacking your normal organs. You'll get inflammation. You'll essentially, like, your immune system will destroy yourself, and you don't want that. But if it's too cold, then it's not going to attack the things that it needs to attack, and you'll get like infections and tumors and things like that. And so immune checkpoints are basically this system the immune system has built in so that you attack the things, or so that it attacks the things it needs to attack, but doesn't attack your normal organs. So exactly like Goldilocks, basically, the immune system needs to get it just right. And now I'm showing you the more detailed immunology level figure. So this is a more detailed description of how the immune therapy medications work. And I have on the left panel, that's how ipilimumab works. And then on the right panel, that's how the PD-1 antibodies, so pembrolizumab, nivolumab, and atezolizumab, that's how they work. I'll go through from left to right. So you're looking at the same dendritic cell and T cell. And I think the real concept here is that the T cells have to go from inactive to active. And then when they're active, if you want them to attack the tumor, they have to stay active. They have to keep attacking. So looking at the left, the red thing, I wish I had a pointer, but the red thing coming out of the T cell on the left panel, that's CTLA-4. And that's sort of like a built-in break. And ipilimumab works there. So the T cell basically, to become active, it needs 2 go signals. And CTLA-4 is a break. But when you block that break, then the T cell keeps getting these go signals. And so you keep taking your inactive T cell and letting it become active. And so that's how you generate this T cell population that can attack the tumor. Then on the right panel, we have pembrolizumab, nivolumab, and atezolizumab. So this is how PD-1 and PD-L1 antibodies work. You have this active T cell. When PD-1 and PD-L1, the red and the purple, when they attach to each other, then you stop getting this activation. The T cell can essentially like turn off or go to sleep or stop this immune response. When you block that, you're kind of taking off that stop sign and you're letting the T cell stay active and like keep doing its job to attack the cancer. So after all of that, that brings us to the question that I was actually supposed to answer today, which is, what should I expect when I'm on melanoma immune therapy? And I hope I'll show you why I really need 8 hours to answer this question, because I would say the short answer is that we don't really know. So immune therapy side effects are related to this balance that I told you about, where you are taking this T cell population that you have, you're using your T cells to attack the tumor, and I told you it's kind of about Goldilocks, about being not too hot, not too cold, but just right. But in a lot of patients, we'll see inflammation. So we'll see that immune response against the cancer, which is what we want to see. But we can also see an immune activation or inflammation in your normal organs. So we'll talk in some more detail about what exactly we see, kind of what the most common side effects are and what the timeline of that looks like. But generally speaking, I chose this picture of dice because when I start someone on immune therapy, I don't know if the immune therapy is going to work for them, and I also don't know what side effects they're going to get. So some of my patients will have no side effects, and others of my patients will have many side effects. And I don't know when I'm talking to someone where on that spectrum they're going to fall. So we'll start with this figure. I took this picture from the patient resource. I linked it on the bottom, and I liked it because it just shows some of the most common side effects that we see. I'll back up a little bit and say that before you start on immune therapy, generally speaking, what I do, and I think what most of my colleagues do as well, is we'll tell you what we think the risk is that you would get a side effect. So the immune therapy side effects, they are this spectrum of inflammation that you can get anywhere in your body. And the reason you can get that is because of the immune activation that we're causing against the cancer. The name for these side effects is immune-related adverse events, or IREs, and that's the word on the top right. That's like a new vocabulary word. So that's how the community in general refers to these side effects. It can refer to so many different symptoms and side effects that people get. When we are talking to people about melanoma immune therapy, before we start you on treatment, we usually will tell you what we think the risk is that you'll get an IRE. And that will depend on what medication that we're using. So it's really hard to give kind of a one-size-fits-all of what I would counsel you without knowing exactly what we would recommend, but I'll give you some ballpark numbers. So when I start someone on just PD-1 antibody, say I'm starting someone on nivolumab or pembrolizumab alone, I generally tell them there's about a 10% risk, about 1 in 10 people will get a significant side effect, a significant IRE from those medications. The risk goes up as you add a second drug. So if we're using a combination, if we're doing nivolumab and relatlimab or Opdualag, I usually tell people that risk is about 20%. And then if I'm using the older combination, the ipilimumab and nivolumab or Opdivo and Yervoy, the risk of that will depend on the doses we're using, but that risk can go up to even 50 or 60%. And so the risk is something that your doctor should be able to counsel you about before you start on the immune therapy, and that can kind of help you know how high risk we think the treatment is. So this slide goes through a lot of the organs where we most commonly see inflammation. So this is a nice outline to kind of help people know what's the most common, but it's not an exhaustive list. So in theory, we can see inflammation in your body at any time, anywhere. The most common, I'll start with skin. Skin is the most common immune-related adverse event that we see. This usually looks like rash, or itchy skin. Another thing we'll see very often in melanoma, we're trying to target melanoma cells which have pigment, they're black, and the normal cells in your skin have pigment too, and we can sometimes see that go away. So patients will get something called vitiligo, it says that on the slide, where they'll get like white patches on the skin. A lot of people will come to me and say, why are my eyelashes white all of a sudden? We see that all the time. I know some of you in this room have told me about your white eyelashes. That's very common. The next thing that we see a lot of times are endocrine side effects. So the slide lists kind of examples. The thyroid is the most common. So we'll see inflammation in the thyroid. We'll also can see inflammation in the pituitary gland. Something that's unique about endocrine side effects. So when I talk about IREs in general, for the most part, they're reversible. So if they're serious, and we'll talk about treatment on the next slide, or maybe 2 slides from now, if they're serious, we'll give people steroids, and usually the steroids will reverse that inflammation. But the endocrine side effects are unique because they're often permanent. So if you were to get thyroid inflammation, this is actually very common. So we see thyroid inflammation in about 10% of people, about 1 in 10 people that will get a PD-1 or PD-L1, so people that get nivolumab or pembrolizumab. When that happens, we'll start a thyroid hormone replacement. So this is a pill, you take it once a day. It's levothyroxine, or the brand name is Synthroid. And that is something that our patients, I tell them generally, will have to stay on for the rest of your life, even after stopping treatment. And that's something that's unique about the endocrine side effects. Other side effects listed here, so we really commonly will see GI side effects, so diarrhea. Colitis just refers to inflammation in the colon. That's very common. And then liver inflammation as well. Also very common, I would say typically we pick that up on blood work. So we do check your labs, including your endocrine labs, your kidney and liver function, your blood counts before every treatment to make sure that it's safe to continue on with the treatment and to see if you're having any side effects. And then the final side effect listed here is lung inflammation, and the medical term for that is pneumonitis. That can lead to symptoms like shortness of breath or cough or fevers. And I know Hannah in her talk talked a lot about how you know your body better than any of us. You know if something is going on. You know if there's something that you're worried about. I would say same thing for IREs. For our patients who are getting immune therapy, we see you every time we give you treatment and we ask you about side effects. But you're the one that knows your body the best. You're the one that knows how you're doing every single day. And in the event you were on immune therapy and you notice something changing in your health, something didn't feel right, something you were worried about, we want you to call us right away and tell us what's going on so that we can tell you kind of what we think, make recommendations. Do we need to check labs? Do we need to treat you? So we definitely are here for that and absolutely want to hear from you if there's something that's changing on immune therapy. There's a couple things about immune therapy side effects that I get asked a lot about in clinic that I thought I would go over. The first one is timing of side effects. I think a lot of patients will have experience with a loved one who's gotten chemotherapy, and so a lot of people will come to clinic thinking that they might go home after treatment and feel bad right away, or that if they come back in 3 weeks and they haven't gotten a side effect, then they're not going to get a side effect. And immune therapy side effects are unique and they take longer to develop. So this slide, it just shows, I think it's a little tricky to interpret, but it shows kind of the timing of when these side effects come up. And I think what I would say as a general rule is that immune-related adverse events, when they happen, tend to happen weeks within up to the first few months after starting immune therapy. So it's really common for people to go home after the infusion and have some fatigue that day or the next day. But the actual most common timing of getting a really significant side effect is usually after a couple of weeks or even after a couple of doses. So on the left, you can see the timing for the most common, that's skin and GI, like the bowel side effects. And you can see on the horizontal x-axis on the bottom, it has time in weeks. Skin is often the first side effect to develop. You can see kind of that around the 3 or 4 week mark. And then you see GI as well with a really big peak there. That yellow line like really goes up kind of around 6 or 8 weeks after starting treatment. So just to give you a ballpark of what we expect timeline-wise, generally speaking, if I had to give you a prediction of what's most common, we don't expect to see these side effects right away. We expect it to take a few weeks or even a few months. Some of the less common IREs are on the right, so that's endocrine, liver, and then lung side effects. And again, you can see them like really starting to peak around 8 or 10 weeks after starting treatment. So then this slide is about how do we treat IREs. And I'll just reiterate here, I think I tell this to everyone when they start treatment with me. I've already said it several times. We see you with treatment. We don't see you every single day in between. the chance if someone's going to develop an IRE that we need to treat, the chance that would actually happen on the day I'm seeing you in clinic is really unlikely. So most of these things are side effects that will show up when you're at home, and we absolutely want to be called if you notice something different. We want to hear about it. We don't want you trying to tough it out at home or trying to see, like, can I deal with it on my own? Let's see if it gets better. We just want to hear from you. That's how I think the way that IREs are managed the best is when we identify them early and we're able to treat them early. I also will say, I know a lot of you see our team here on main campus, but immune therapies are used so commonly across oncology for all different kinds of cancer. And so I would say that your oncologist, no matter who they are or what kind of cancer they usually treat, these medications are used so commonly, they have a lot of experience managing IREs. And so there's just a lot of guidelines and resources to help us. And so I think communicating with your team, whoever that is, I would say most of my colleagues in the community and here at Cleveland Clinic are very competent in managing these side effects. So if you start on this figure with the purple boxes on the bottom, you can see that we think about IREs as far as grade. And the grade, it really helps us as a community make sure that we are providing consistent care to our patients, and so that we know that we're being consistent about like how serious the side effect is. You don't need to know the grades, but you can just think of it as like mild, moderate, severe, or very severe. So it helps us as your physicians or providers know how serious your side effect is. Generally speaking, for mild side effects, we manage those by controlling your symptoms. And so for something like rash, that might be a topical steroid, a cream, or it might be just a moisturizing cream. Hannah's best friend, Aquaphor, might come into play here. For a more serious side effect, then a lot of times we'll use steroids. And you can think of steroids as essentially kind of turning off or reversing this immune activation that's too strong and that's attacking your normal organs. So we'll use steroids to help reverse these side effects. When I am thinking about treating an IRE, there's two questions that I usually feel like I have to answer. And the first one is, do I need to put this person on steroids to help get their immune inflammation under control? And the second one is, do I need to take a break from treatment? Do I need to pause their immune therapy or stop their immune therapy? Those questions kind of go together. So I do think about it. If I'm putting someone on steroids for their IRE, then typically we do pause treatment as well. And I'll have another slide on that next. As far as what to expect with steroids, I think we do try to minimize how much steroid we have people on and for how long, but we also know that if we take you off of steroids too quickly, then the side effects can come back, the IRE can come back. So I would say generally I would expect, again, really hard to give you a one-size-fits-all answer. Do my best to give you kind of a framework of how I think about it. I usually will do high-dose steroids, and so that means like 1 milligram per kilogram of prednisone. For an average-sized person, that might be 80 or 100 milligrams of prednisone a day, which is a high dose. And if you were being started on steroids for an immune therapy side effect, then I would have the expectation of being on steroids at least 4 to 6 weeks to allow the immune activation enough time to cool down so that as we taper the steroids, we feel confident that the inflammation won't come back. As far as what to expect for if you got a side effect, how quickly it would improve, when we start people on steroids, we do expect to see that side effect getting better pretty quickly. So some examples, if we had somebody with colitis or bowel inflammation and we admitted them to the hospital, I would want them, if I put them on IV steroids, I would want them to be improving within 2 to 3 days. Another example, there's someone from my clinic, I put on steroids for liver inflammation on Wednesday, and their labs were better on Friday. So we expect to see this pretty rapid improvement. So when I was a trainee, I guess sort of pun intended with the training wheels, somebody in my mentor's clinic said something like immune therapy is like training wheels for my immune system, and I really love that, and I think I'll just be using it for the rest of my career, but I can't credit them because I don't remember who they are. But I think this is really important. When we are starting people on steroids for side effects, there is a lot of concern a lot of times in clinic about, well, if we're stopping my treatment, does that mean that it's going to stop working? Is this a bad thing? Is it a bad thing that we had to start steroids? Is it a bad thing that we had to take a break from immune therapy? And I think it's important to know that I actually don't think of it that way. So this is where the training wheels analogy comes in. So the immune therapy can kind of teach your T cells what to do. And so that's like the training wheels. The T cells can then remember that potentially for a long, long time, even after we stop treatment. So we know that for melanoma, these immune therapies can work for a very, very long time. And for some patients, even one dose, like there are patients in our clinic who've gotten only one dose of immune therapy, and that was enough. And so I tell patients when they have to get started on steroids for a side effect, one, in some ways I like to see a side effect. We know that some side effects are associated with a better immune response. So sometimes I'm like, well, I'm glad to see this. It means your immune system is active. It's doing something. That's what I want. And then we also know that these immune therapies can work for a long, long time, even if we're not continuing treatment. So we do feel very comfortable taking a break from treatment. I think that's very important to know. So I've probably gone way over my time, but I think still under the 8 hours. So I'll breeze through these last slides as quickly as I can. I did want to tell you about Pharmacovigilance Clinic. It's a specific resource we have here at Cleveland Clinic. The idea is this is a group of providers or physicians from different specialties, and everyone has an interest in caring for patients who've had IREs. So we're across different specialties. They came and did a professional photo shoot. Cleveland Clinic loves professional photo shoots. I've learned, actually did 2 that day. So from left to right, we have Dr. Zhao from endocrinology, Dr. Kunchak from neurology, Dr. Abdo from pulmonology, that's me in the middle, I'm a medical oncologist, Dr. Mucha, who's a critical care doctor who runs our oncology ICU, Dr. Calabrese, who's a rheumatologist, and then behind her, Dr. Smith, who's a pulmonologist, and Dr. Jana, who's a hepatologist. So all of these people that really have clinical interest in helping to care for patients with IREs and research interests. And so this has led to this really nice clinic on Friday afternoons in Taussig where there's, oh, and I didn't mention Dr. Kabur, who was here earlier. She's a dermatologist, and she actually has reserved slots on her template also to see patients with skin side effects. And so it's all of these people that basically have these reserved slots on their schedules so that we can help get patients with IREs in quickly. So who are the patients that we see in Pharmacovigilance Clinic? I have a few examples. So I would say one would be patients who need coordinated care with a lot of different specialties. So I share a lot of patients with Dr. Zhao and Dr. Calabrese. They come to Taussig on Friday afternoons, and some of our patients will see all 3 of us back to back. And so it's just a nice way to streamline your appointments. And then the other patients who I think are really good patients to be seen in this clinic are patients who have more difficult to manage IREs or more difficult to diagnose IREs. So a lot of IREs, say that you have really straightforward colitis and we put you on steroids and you get better. That's great. But a lot of people will have really complicated IREs. We can't quite figure out, what organ exactly is involved, or you have multiple organs involved, or we've given you a lot of different treatments, but you're still having symptoms. Some people will have longer lasting IREs. So these are patients that I think really can benefit from the Pharmacovigilance Clinic. I have 2 examples for you, and then I'll stop. So the first one is just a schedule from a patient who sees me and Dr. Calabrese and Dr. Zhao, and I just showed you his schedule so you could see he saw the 3 of us on the same day within like 90 minutes. It's a pain to come downtown. It's a long drive. You have to pay for parking, etc. So seeing all of us on the same day is really nice for our patients. It's also nice for me selfishly if I have any questions about you. Your other doctors are sitting next to me and I can ask them, so I really like that. And then this is an example case just of somebody that was having an IRE that was a little more difficult. This was a young person who got chemotherapy and pembrolizumab for lymphoma on a clinical trial. They started getting, I didn't make this slide for a patient audience, so arthralgias are like muscle and joint pains. They started getting muscle and joint pains so bad they actually couldn't walk. They had to move back in with their parents. This was going on for like months. They came to Pharmacovigilance Clinic. They were like, I just don't quite know what's going on. We thought this was from immune therapy. We started them on prednisone and sent them to rheumatology. Dr. Calabrese sees them. Within like a month when they went to rheumatology, they were already better on steroids. She put them on another medicine called tocilizumab. And then about 2 months after their initial pharmacovigilance referral, she saw them back. They said their joint pain was 2 on a scale of 1 to 10, and they were basically back to their baseline. So just a nice example for patients that can really benefit from this kind of model. And then I didn't have a place elsewhere in my presentation to include this. I did want to highlight this resource for you as well. This is from AIM with immunotherapy. And this is kind of patient worksheets to help you know what to look for and kind of when to call your doctor. I thought these were really nice. They're screenshots, they're just a few examples. This one is for lung and breathing and then diarrhea and stomach. And I liked it because They list the side effects. It's a worksheet, so this is like many pages, but I only showed you two. So it gives you symptoms, and then it tells you when you call your doctor, what should you tell them. So for example, like, when did you first notice the changes? Like, what do your stools look like? Are you bleeding? Things like that. What are some red flags? So really helpful kind of resource for you to have, and the website is here. And then finally, these are the references I used. I listed the links here. I downloaded them all for free online at those links, so that if you're interested in reading more, you should have access to those as well. And thank you everyone for your attention.
Thank you so much, Dr. Kennedy. Yeah, we're definitely really grateful that we have this resource to take you through your journey. Next, I want to welcome Emily Chang, who's our melanoma pharmacist. Excuse me, I need to come closer to this microphone. Emily Chang is our melanoma pharmacist. We have dedicated pharmacists to work with our program, and she's going to talk to you about if BRF/MEK tablets targeted therapy is an option that you're considering along your journey. Thank you, Emily.
Can you all hear me okay? Perfect. Thank you, Dr. Truong. But again, my name is Emily Chang. I do have 2 double H's. It's not a typo. But today I will be talking about managing your treatment on BRAF and MEK targeted therapy. Just a quick raise of hand. Has any of you currently on BRAF or BRAF plus MEK inhibitor, or has been on BRAF MEK inhibitor? Just a few of you. All right, so we'll just get you started. So is it the screen? We also have an online audience. Oh, that is true, but from the live audience. So some of the objectives today that we'll go over is discussing targeted therapies used in melanoma patients with a BRAF V600 mutation, and to describe the common side effects associated with BRAF and MEK inhibitors, as well as some of the common management strategies associated with that. So the combination therapy, so we have BRAF and MEK inhibitors. This is shown to be a very effective treatment option in melanoma cancer patients, primarily with patients who have a BRAF mutation. And more in particular, this is BRAF V600. It has been shown that by targeting this particular mutation, it slows down the progression of cancer and stops and kills the cancer cells. Later on, adding something called MEK inhibitors has shown to help improve the treatment effectiveness, as well as decrease some of the toxicities associated with BRAF inhibitors. So listed here are the 3 different combinations of the BRAF and MEK inhibitors. We have something called vemurafenib plus cobimetinib, dabrafenib plus trametinib, as well as encorafenib plus binimetinib. So it wouldn't feel complete for me to not talk about some of the drug information as a pharmacist before diving into the side effects. So just going to highlight a few things such as doses and administration. So first with vemurafenib, or also known as Zelboraf as the brand name, typically the dose is 960 milligrams every 12 hours, and you'd want to take this with a full glass of water. Dabrafenib, or the brand name Tafinlar, is taken as 150 milligrams every 12 hours, and you'd want to take this on an empty stomach, so typically at least 1 hour before a meal or 2 hours after a meal. And then last, we have encorafenib. This one is 450 milligrams taken once a day, and you can take this with or without food. Next, we have the MEK inhibitors. So the 3 are cobimetinib, trametinib, and binimetinib. The doses here, we have cobimetinib, which is kind of unique in terms of how we dose or how patients take this medication. So this one is going to be, you take it on a daily basis, but for 3 weeks. So you take it for 3 weeks, and then it's followed by a 1-week break. So kind of like 3 weeks on and 1 week off. You want to take this with, or you can take this with or without food. So next is trametinib, also the brand name as Mekinist. You can take this on an empty stomach, so again, at least 1 hour before or 2 hours after a meal. This one is a little bit more unique in terms of how to store the medication. The tablets for trametinib, you want to store this refrigerated, whereas the other 5 medications, you can store it at room temperature. Binimetinib as the last one, or the brand name Mektovi, you take this 45 milligrams every 12 hours, and you can take this with or without food. So what are some of those side effects? So focusing on this, the combination of BRAF and MEK inhibitors do have a wide variety of side effects, and I kind of listed the common ones within each class, but it's important to note that the percentage or the incidence of each medication within the class can vary as well. So some of the side effects that are more common with BRAF inhibitors would be a rash, and typically it's maculopapular, meaning that it could be flat and or it could be bumpy. Fever is another potential side effect, but this is really more associated with the BRAFinib and trametinib and less common with the other combinations. Other GI symptoms could be nausea, vomiting, and diarrhea, as well as increased liver enzymes. Dry skin or thickening of the skin can also occur as well. On the other side with MEK inhibitors, some of the notable side effects, again, you see rash, but it is a different type of rash. It's more acne-like. Swelling in the hands and the feet can occur, as well as some ocular side effects, such as light sensitivity and blurred vision. And again, these are some of the highlighted toxicities. There are some overlapping side effects between the two classes. So first, focusing on fevers. So fever, it's when your body temperature is greater than or equal to 100.4 degrees Fahrenheit. You may or may not have flu-like symptoms such as chills or night sweats. And again, as previously mentioned, this is more common with dabrafenib and trametinib. If you were to have have a fever, it is very important that you call your doctor and to let them know, because they may instruct you to hold your treatment. And in the meantime, when you're holding your treatment, you can take over-the-counter medications called antipyretics, or known as Tylenol or ibuprofen, and this is to help lower your fever. Drinking plenty of fluids is also very important to help stay hydrated while you are fevering. I like to think of what my mom did to me when I was a kid when I had a fever. So having cold compresses on your forehead and your neck, as well as taking a cool or slightly warm bath. When you are fever-free, at least for 24 hours, your provider might tell you to resume the treatment. And then sometimes in cases of severe fevers or fevers that return or are recurrent, your doctor might say to start low doses of steroids, so that could be something that you may start. So dermatologic side effects. So skin-related symptoms are the more common side effects that we would see with these combination BRAF and MEK inhibitors. So what I wanted to focus on are the rashes, something called plantar palmar hyperkeratosis, as well as photosensitivity. So with rashes, like I mentioned, with BRAF inhibitors, you see macular papular or the flat and bumpy rashes. And with the MEK inhibitors, you see the acne-like rashes. Usually we would preventatively and treat using topical emollients, so Hannah's best friend, Aquaphor, as well as Eucerin, so having those big tubs at the grocery store. You can also take allergy medications or apply topical steroids. So these are some of the things that your doctor might tell you to do, and it just depends on the severity or the type of symptoms you have. Plantar palmar hyperkeratosis. So this is quite worthy, so I'll abbreviate this as PPH. But this is kind of a skin thickening on the palms of your hands and the soles of your feet. So because of this, we like to recommend avoid tight clothing and shoes that can cause friction and pressure on your skin, and this is to help prevent pain from happening. So when you wear tight shoes, it could hurt, so just avoiding something like tight shoes. You can also apply topical emollients, again, Aquaphor or Eucerin, moisturizers or something known as keratolytics. This could be things like urea cream, if you've ever heard of it. There is a brand that I like to call as Utter Cream. So you'll see like a cow picture on the bottle, and then salicylic acid as well. In terms of photosensitivity, this is more common with vemurafenib. With photosensitivity, it can happen after an hour of sun exposure. So we always recommend wearing protective clothing and applying broad spectrum sunscreen at least with an SPF of 30. So one of the other potential side effects that could happen is a development of new skin cancers or lesions. This is very rare, but I wanted to mention this so that you all are aware in case you look it up on the internet and you see this, and I didn't mention this. But some of the ones that were reported were squamous cell carcinoma, or more so cutaneous squamous cell carcinoma. And this is a type of, it can potentially cause an ulcer to form. Keratoacanthoma and skin papilloma are typically nodules or lesions that can grow on the skin, but these are typically benign. It has been found that the incidence of this is really pretty low when you're taking both the BRAF and MEK inhibitors, which you will be instead of taking one of them, the BRAF inhibitors. So typically the percentages that have been reported has been less than 3 to 4%. So it's very important, along with this and the previous slides of other potential skin symptoms, that routine dermatologic exams are done prior to starting the medication, every 2 months, and then up to 6 months after you discontinue. Also, it's important that you do see a dermatologist so that they could be there to help with any potential interventions. So then in terms of cardiovascular side effects, we have cardiomyopathy and QTc prolongation. So what is cardiomyopathy? It's typically when your heart is having a difficult time with pumping out blood throughout the body. So this can occur when there's a decrease in ejection fraction. So essentially meaning that it's a measure in percentage of how much blood is pumping out per heartbeat. So this is something we would monitor using an echocardiogram, also known as echo. So we would want to routinely monitor before you start treatment and during your treatment. Typically, it's 1 month after you start treatment and then every 2 to 3 months afterwards. And then if you do become symptomatic, we will also refer you to cardiology. But for the most part, we will be monitoring the changes in the ejection fraction. And if it is, if there is a decrease from your baseline, then we might adjust or modify your current treatment, the doses, or holding the doses. But it just depends on the grade and the severity. QTc prolongation, so that happens when your heart is struggling or it takes a little bit longer to contract and relax. So this can sometimes affect your heart rhythm. So things that we would monitor would be an electrocardiogram or an EKG or ECG, just to make sure your heart rhythm is okay, and as well as your electrolytes. So things like potassium and calcium. We would treat, or we would want to monitor before you start treatment again, and then during treatment as well. So again, depending on the grade and severity, we would make adjustments with your treatment. There are some GI toxicities as well with the BRAF and MEK inhibitor combination. So diarrhea being one of them. This is probably more common with vemurafenib and less common with the other two combinations. So always, number one is staying hydrated with water, as well as any electrolyte supplements like Gatorade or Pedialyte. There are over-the-counter medications if you've ever tried Imodium, and then there are also prescription medications if Imodium doesn't help. We can consider diet modifications to help decrease the symptoms of the diarrhea. So you could eat meals a little bit more frequently, as well as on a BRAT diet. So bananas, rice, apples, and toast. So that could potentially be something to help decrease the diarrhea. Typically, we would have you continue treatment with the BRAF and MEK inhibitor, but if it was severe enough, we may consider holding treatment until the symptoms resolve. Liver dysfunction or an increase in liver enzymes is another thing that we may see. So we will also monitor your liver function test prior to starting treatment as well as during treatment. Depending on how high your liver enzymes could get, we could potentially hold treatment in considering lowering the dose of the treatment. In terms of ocular side effects, so again, this is rare as well. Some of the things that we may potentially see or not see, but reported, is conjunctivitis, also known as pink eye, uveitis, which is eye inflammation, and dry eyes. This is usually it's managed with topical steroids, and but it's very important that if you do have any changes to your vision, any blurred vision, to let your doctor know so that you should be seen by an eye doctor. Retinopathy and retinal vein occlusion is also potential side effects that were reported. Again, very rare, but things to be aware of. Retinopathy is damage to the retina, whereas retinal vein occlusion is a blockage in the vein that drains blood through the retina. So, for example, for retinal vein occlusion, if we do see that you're confirmed with retinal vein occlusion, that's when we would permanently stop your treatment. So I talked about a lot of dose modifications or interrupting and holding the BRAF and MEK inhibitors. I just wanted to be complete and also include what levels of the dose reduction there are. You can see the BRAF inhibitors in blue and the MEK inhibitors in green. There are typically 2 to 3 dose level reductions before we discontinue the BRAF and MEK inhibitors. However, depending on the grade and severity, it may kind of go all over the place. So in summary, there are various targeted combination therapies used to treat melanoma patients with a BRAF V600 mutation. It's important to be aware of the common side effects and how to manage those side effects and kind of or know what to expect in terms of what your doctor may recommend to you. And it's always important to reach out to your doctor and to your treatment team for any questions and with any symptoms that might appear so that we can better tell you what we can do to help. And that's all that I have for you. Thank you for listening.
Thank you very much, Emily. It is a really great time. We have many different types of classes of medications, and it's good to understand where we're coming from here. I'm going to ask, actually, Emily, stay right here. I'm going to ask NP Burke also to come to the front, Dr. Kennedy and Dr. Isaacs. If you have had any questions, please send them along. I see Dr. Tafaro also in the audience, if you could come down as well. Yeah, if you have any questions, you can also raise your hand and we'll get your question from you so we can answer it. I'd also like to invite Charles Tobin and Bob Samarigo to come join us down here as well. These are patients and friends right from here in our community, and we're so excited they're here today to tell us their stories.
So while she does that, I'm just going to take a moment. So I want to thank Dr. Kennedy for mentioning the side effects management sheets. So she pointed out that site because it's a site we typically send providers to. But I do want to let you know that all of those side effect management sheets that she referred to are on that site, but they're also on the AIM at Melanoma site. if you look at the side effect management sheet, the reason I would suggest going to AIM at melanoma is because that one also includes side effect management sheets for the targeted therapies. The site that she pointed out only has the immunotherapies, and AIM at melanoma has the side effect management ones. If you have difficulty finding them, we have a little chat feature on the website you could use. You can contact us and we can get them to you. You can reach out to the PA that I mentioned earlier. She can also send those to you. So there's many different ways that we can get those to you. And again, they are all pretty much updated and really hopefully very helpful. So, and again, if you have a question, please raise your hand and I will find you. And Dr. Marco.
Okay. Can you all hear me? Okay, I'm going to stand over here so I'm not so far off. So I want to introduce two special guests we have here with us today. There's Bob Samarigo here in the yellow shirt. Hi. And Charles Tobin next to him. Bob, could you start telling us, how you were diagnosed just in a few minutes?
Yeah, real quick. Let me just start off by, I was at my doctor's office this week, and he was sitting there and he was writing out some notes and stuff like that, and he reaches in his pocket and he pulls out a rectal thermometer and he looks at me and says, some butthole's got my pen. But anyway,
a little medical joke.
Yeah, a little joke to start things off. But anyway, I started with going for a biopsy, and I had a little spot on my back. And next thing I know, I never thought I would have any kind of signs of melanoma at age 69. And moving forward, I have it. I was introduced to Dr. Truong and Dr. Tafaro here, and we just kept moving forward. And I'm on my 4th treatment so far since the first of the year, and my tumor has shrank so much. And I can't be so thankful to everybody. But also, I'd like to say something like Hannah. Those pictures were just, mine wasn't that bad, and they would give her something else to see. I mean, I'm so glad. But everything's been going along really well for me. So I got one more treatment. Thank you very much. Thank you.
And I mean, I'll chime in, Bob. I'm so glad you could join us because, Dr. Tafaro and I were talking. I mean, you are really on the new course of treatment that was recently really shared, with the public, which is that you received your immunotherapy before you're going to surgery. And that's because it's a new approach where we've really found that if there is melanoma we're already seeing that's beyond the skin, and you had this lump under your arm, that is really almost a 50% improvement if you do it ahead of time. I'm going to let Charles tell us his story, and then I have some follow-up questions for you because, we just want to share with everyone your journeys. Thank you.
Good morning, everybody. I'm Charles Tobin. I'm 81 years old, and in September of 2020, after surviving a heart attack, where my main artery in my heart was blocked by 99%, and I had no symptoms. I'm a person who bikes in the valley approximately 18 miles a day, every single day, even in February if the weather permits. And I had absolutely no clue there was anything wrong with my heart. And there I was, having 2 stents put in my heart. And then a month and a half after that, I was diagnosed with stage 2 melanoma, 2B. And right away, they scheduled me for surgery. And the surgery, at first they thought it was very mild, like stage 1. And then they discovered after the major biopsy that it wasn't mild, it was 2B. So I had another surgery in December 14th of 2020 by Dr. Brian Gassman, and who you all know, I'm sure, better than I do, an amazing surgeon. There were 5 or 6 surgeons in the operating room when they operated on me, and at least 9 people working on me. And they put my head back together again. I left the hospital that day with a cone on top of my head about 4 inches high, and hoping that that would go down, and it did. And that was the beginning of this long journey that I've been on for the past almost 4 years. And I just feel very, very fortunate that I am this close to Cleveland Clinic and all the wonderful people, all the wonderful caregivers that have saved my life. And I want to say something about the care that I received. I just think it is absolutely the best possible place to be associated, to be a patient of the Cleveland Clinic for what I had to deal with. And not only did you treat me with all the wonderful medicines and put me in a study that basically gave all that service to me for free, and I must have had 15 or 20 CAT scans, and these CAT scans they're billed out at like $12,000 a piece. There's no way I could afford all this. And through all of that, they didn't just treat me with the medicine and the surgery. They also made available to me at no cost psychological help for the enormous, emotional tsunami that you have to deal with when you're given a death sentence, which is the way I look at getting melanoma. I know people who have died from it, young people, stronger and younger than me. And that's what I was thinking. I was going to lose everything, my wife, my children, my grandchildren. That didn't happen. And I have nothing but the highest praise for this organization. And I want to tell you that even including the weather we deal with in the wintertime, the severe weather of February, through all of that, every single time I came down here, I never had to wait more than 5 minutes beyond the appointment scheduled time. And that is remarkable. I've worked in the corporate world as an aerospace engineer. I've worked with giant corporations like Boeing and McDonnell Douglas and Boeing Vertol. And that doesn't happen in the real world. You hear these stories about people waiting. And when you're sick, it's hard to wait. And you can just imagine what a relief that was to know that I was going to be seen every single time I came down here. And that if I had a question, it was taken care of immediately. And I have nothing but the highest possible praise for this organization.
Thank you so much, Charles.
I do have a question
Yes.
for Hannah.
Yeah.
I have had melanoma at the very top of my head, and everything I know about melanoma is they go deep. They try to get the margins as big as possible, but you can't go deep on the top of your head. Obviously, you've got I don't relate to millimeters, I'm going to say maybe 1/8 of an inch of skin, and then you're into bone. So my question is, I know in breast cancer, which affects 1 woman in 8, that they're using artificial intelligence now to make early diagnostic analysis of these little smudges that appear on what do they call that exam when they, mammogram, yeah. These tiny little smears that could be cancer, they're using artificial intelligence to analyze that. And that's helping a lot, I'm hearing. Are they using that to determine melanoma for something like this on a man?
Oh, actually, I'll jump in here. And Dr. Kaber had a commitment, so she can't be here. Yeah, so actually also in melanoma, there are initiatives to use artificial intelligence to look at the skin and identify melanoma, either just visually. There's some work actually, and I note that you were diagnosed during the pandemic,
right.
And a lot of that work was done at the time with patients taking a picture, sending it in, and so sort of using an image rather than usually just your eyes to diagnose melanoma, but also looking at a biopsy and identifying features that might be higher risk or lower risk. It's very early. So I wouldn't say that it's prime time at this time to use it, but that is an exciting feature to use, another set of, I call it a second, I don't call it the only, so it's artificial, but a second set of eyes to basically double check the features.
That's what the strong point for artificial intelligence. It thrives on data.
Yeah.
And the more data you give it, the more accurate it is. But one final question for Hannah, and that is, are the statistics for reoccurrence any different for someone that has their melanoma on the top of their head versus somewhere else? Because I just don't understand how you can get everything when the skin is so thin.
So the statistics for your reoccurrence has to do with the type of melanoma you had. So it all comes together with like that pathology report. Your Breslow, what was the mitotic rate, the ulceration? Dr. Tafaro, who I work with now, might have more insight on that, but on the scalp, we do take adequate margins there.
But it's not very deep. That's my concern, is how can you get a great margin if it's not there to get?
Well, I would also say, which is why I was so glad you also had time to join us today.
Thank you.
That's where we all work together. There's a surgery, and then there are medicines that we do afterwards to reduce your recurrence risk. And indeed, that's what you went through.
Right.
So both of you got immunotherapy in different contexts. Bob got it prior to surgery. You did it after surgery. And our hope is that that's how you can get a cancer cell too. You can get it by surgery, and then whatever you cannot catch by surgery, we can do it like Dr. Kennedy showed us. You can get the invaders in another way. I was going to ask you guys, how was your journey through treatment? Both of you had some side effect. Bob, I'll have you start first.
Yeah, I didn't have any side effects whatsoever except my hands. My hands got a little blistery and the skin started peeling off them. But and that was it for me. And, you go read some of the side effects. I was very grateful that that was the only thing that happened to me. So yeah, and right now it's healing up very well. But I keep, putting lotion on them and using the Aquaphor. Who was the one that went to Aquaphor? But anyway, it's great stuff. It's like, it's kind of like, butt paste there for a little baby or something. It's real greasy, but it really works well. And I put it on at night and rub my hands and put some rubber gloves on it and things like that. And it's been tremendous. And like I said, I'm so fortunate. And like you said, we've had a great team down here. Dr. Varro, Taylor up there. I see Taylor all the time. It's just it's been a great journey for me too as well.
How about you, Charles?
I knew immediately that I was on the hot stuff, the nivolumab, because I had an immediate reaction on my hands and my back. And things, these ulcerations that appeared were so strange. They were alien creatures on me. I've never seen anything like this. And I've never had skin problems, but I sure had them. And I think we opted out of the immunotherapy around July or August after 4 or 5 treatments. It was so severe. Mm-hmm. And I reacted with skin rash on my hands, my back, and my feet. And it was quite painful, but and it took a long time for it to settle down. And it's probably like 2 years now, and I can see that I'm about 80% through it. So I'm optimistic. But if that's the price I had to pay, that was a cheap price.
Well, I was going to say, we do have data that for those who have side effects that improve, you have a better recurrence-free survival, at least by statistics.
Right.
So that's really good. I also wanted to ask you, and maybe not all in the audience know, when we actually offer many different research trials here at the Cleveland Clinic, but you don't always know what you're getting. So there are some trials where everyone gets the same treatment. You were on a trial where half of the patients, actually 2 out of 3 patients would get the drug and 1 would get placebo. Mm-hmm. How was that decision to go on treatment for you?
Well, I'm extremely glad that they put me on the treatment, not the placebo, because I really feel that I was at risk. My life was at risk. And if we had waited another year, it might have been a bad move for me. That might have been a bad outcome. And again, I cannot overemphasize the gratitude that I have for Cleveland Clinic extending the treatment to beyond just the immunotherapy and including the psychological help for dealing with the emotional side of this battle. And I had Dr. Melissa Walt to help me with that, and Carly Temple, the social worker, was hugely helpful. So I just feel very fortunate that I was able to be saved by the Cleveland Clinic. So thank you for that.
Thank you for sharing your story. I want to delve into some of the questions our audience has for you all here, and actually to connect with something both you and Bob told us, and also Dr. Kennedy shared with us. There was a question, there's two questions that are related. One was, should I worry if I have to go off treatment if I have a side effect, which is something you experienced, Charles. And then the other question from another audience member out there, thank you for asking it. Should I worry if I don't have side effects, that the treatment isn't working? Dr. Kennedy, what illuminate us? What do you think here?
Those are such important questions. I feel like I spend 50% of my day trying to answer them. It's really hard to answer, it's so hard to give a blanket answer. I guess I'll start with the first one. So, should I worry if I have to take a break on treatment because of side effects? Generally speaking, I would say, back to that training wheel slide, I would say I generally feel very comfortable holding treatment because of side effects. So I wouldn't necessarily say that just because you're having a side effect and we have to hold treatment that I would worry. I think it's always very personalized. So we take kind of the whole situation into account. And so say that somebody is having a really nice response to treatment, their melanoma is shrinking, the scans are looking really good, or say that they're like you, they were getting treatment to help prevent melanoma from coming back and their scans were looking good and there's no melanoma on the scans, then in that case, we really don't, I'm always thinking about what's the least amount of immune therapy I have to give someone, to help them get the benefit, but then not give them side effects. And we actually don't know. And so if someone's doing really well on immune therapy, but they're having a side effect, I don't think it's a bad thing that we would have to hold treatment. And then the flip side of that is, well, if I don't get any side effects, does that mean the immune therapy isn't going to work? It doesn't necessarily mean the immune therapy isn't going to work. So we also have long-term survivors in our clinics that didn't have any side effects. And so it's just very, very unpredictable. I always feel like when I meet people, I just don't know, are you going to have side effects? If you have a side effect, what does that mean? I think we don't really know. I think there's a lot that we still have to learn.
And I mean, for some regimens, and I was grateful that you shared statistics, it was like 15%, that are severe versus others, let's say a combination where it's much more. So, we don't know, but, you can gauge it a little bit. And I mean, great that you're doing well, Bob. And
I just want to touch base on that because we're talking about side effects. I went through my 4th treatment this week, but I didn't really start having any kind of side effects until my 3rd treatment. So 1st, 2nd, I didn't have anything. And again, was it really working? Like Dr. Kennedy said. And, and all of a sudden, my hands just broke out in these little bumps and, and then of course, I called the office and I got a call back real quick and we were moving forward real easy. It worked out well for us.
I have a second question, which maybe, Bob, you might remember, but also Dr. Isaacs yesterday addressed this to physicians. So there are two related questions. One was, how and when do you find out if you have the gene, the BRAF gene? And another question, does it matter whether I started on a targeted therapy or immunotherapy? If I have stage 4 melanoma. Dr. Isaacs, what do you think?
The first question about when do you find out about if you have a BRAF mutation, there's a couple different ways we do the testing, but typically for most people at the time of diagnosis, we take the biopsy sample and they can do testing to determine if you have it. Sometimes the tests we order just test for that BRAF mutation because we always want to know is it positive or not, so we try to do a quick test. But then sometimes we send more comprehensive genetic testing with, there's different companies that it's sent to. And so you might get a longer report that would include if you have the BRAF mutation in addition to any other genetic mutations. So then the second question, I mean, I think targeted therapy and immune therapy are both treatment options. Right now, we're kind of talking about adjuvant treatments after a surgery. And so I would say there's a lot of debate whether immune therapy or targeted therapy are the best choices after surgery. But the truth is they both work to reduce the risk of melanoma recurrence. They have slightly different side effect profiles. And so it's really a discussion about preferences and side effect profiles. And there's also differences that if you take a targeted therapy, it's an oral medicine, you take it home versus coming into the clinic for an infusion. So it's a complicated question, but the good news is that both of them work in the setting after surgery. If you do have stage 4 melanoma, they're also both effective. In general, now we're moving to starting with immune therapy. So if it's the first time I'm seeing someone, I would favor starting with immune therapy. But I'm not sure.
It can be a mixed picture sometimes.
It can be, yeah, I was going to say, I don't know the details of the person that was asking the question, but if you've done well with targeted therapy, then that's okay. You know, if you're doing well. So at that point, you know, sometimes it is okay to stay on targeted therapy, but it's a very complex discussion.
Yeah.
I'd like to comment on something that you mentioned about imaging and artificial intelligence. You brought up the point of women's mammograms being reviewed. Well, quite frankly, it's a lot different with melanoma, and I get the question all the time, why wasn't this picked up on a CAT scan I had last month or something like that? For breast cancer, pancreatic cancer, other common lung cancers, nobody picks up a 1 millimeter sized lesion. Yet 1 millimeter of melanoma, which is about the thickness of a quarter, can end your life. So on a breast cancer, women don't present with 1 millimeter sized tumors, number one. They're usually centimeters, 10 times that size.
Wow.
Whereas a 1 millimeter thick melanoma is a life-ending problem if not dealt with in a proper fashion. So that's the difference. You can't interpret films for thin melanomas or relatively deadly melanomas. Even a 4 millimeter thick melanoma is not going to show up on PET scans, studies like that, imaging studies. So you need a certain burden of disease for it to be picked up on most imaging studies. So the truth is, melanoma grows on your skin. And the study is, take a look at the skin. If you have an unusual appearing mole that's changed, a change in size, shape, color, it bleeds suddenly, it's painful, it's itchy. All those things patients have told me that when I asked them, what did you think about this? Said, well, I had a freckle there for years. And then it started getting bigger and it was raised up. Nobody comes in and says, I had a CAT scan and they picked up a 1 millimeter thick melanoma on my scalp, because it's not going to be seen. If it's picked up on a scan, then the disease has advanced pretty rapidly or over the course of that time. As far as the depth of invasion, your survival is based on a couple of things. Your thickness of your primary tumor and whether or not this tumor has gone to other things like lymph nodes, other places. So while your scalp is pretty thick, pretty thin, we could probably get almost a centimeter margin down to the bone. And if your melanoma is down to the bone, then it's already a real bad melanoma. So we can get a margin on your scalp. We just don't have as much room to play with. You don't have fat on your scalp like you do. You have some, but a small amount. But if it's on your back, your chest, your belly, your breast, even your face, you have a thicker fat pad on it. So we can get margin. We can get an adequate margin because your tumor itself is not 9 millimeters thick. In some instances it is. So then we take off all the skin down to the bone. Sometimes we even take out bone and reconstruct it. What I think is coming out of this whole thing for patients, and I guess most of you are patients, is cancer care has gotten much more complicated, but much better over my course of delivering care to patients as a surgeon. And what you see here is a team that we didn't always have 30 years ago. It was individual silos. A patient would go to a surgeon and get something cut out, send you to the medical oncologist. Here, everybody sort of works together. Dr. Truong, Dr. Kennedy, Isaacs, Hannah. So you're getting a lot of feedback. We all have a clinic together. If I have a problem, I say, hey, can you take a look at this patient with me? Or can you look at the scan? Every day, Dr. Kennedy, Dr. Isaacs, Dr. Truong will show me something. Can you look at this guy? That's very important. The continuity of care for people with life-ending problems is the most important thing you could have, because people have a less tendency to fall through the cracks with miscommunication among their doctor team. To have Hannah with me every day, I couldn't do this without her. Now, I'm in and out of the room. Hi, how are you? We talk for half an hour about the thing. When I leave, there's a devastated patient there who finds out they have a life-ending problem. Nobody walks out and says, wow, that was fun. I was glad I could see the surgical oncologist today. Boy, what a great day. But having this support structure, particularly people like Hannah and the medical oncologist there, I think is very important to you as a patient, because it is a journey. And we need a lot of people on that bus to support you. It's a lot different than it was 25 years ago. I know all these youngsters up here weren't doing this 25 years ago, but I was. And,
Well, actually, I love where you're going with this discussion, because it helps us end on a very positive note. So I have two questions here for you, Dr. Tafaro. Yes.
Okay. I'm nervous
and
now.
I actually love that this was an audience question, because we discussed this also yesterday among physicians, and it really pushes the edge of what we're doing. And so someone wrote, if treatment results in shrinking a melanoma to such an extent that it has almost disappeared, would surgery still be necessary in each case? And that was a whole panel yesterday, so I would love for Dr. Tafaro to comment
I
on
think
that.
the operative word there is almost.
Almost.
So do you want to leave with almost a little melanoma? So with all these treatments we have, the durability of response is something we're dealing with, and we don't have enough information on all the treatments to say, yes, this is a lifelong.
And I would say, which is why I love that Charles is here with us, that is exactly the question we are asking, and the trials and the study to answer that specific question. So, I started today talking about the community we have and the work we do together, and that's what it takes, right? Is that you have to compare and know whether what is necessary. Several trials have shown that we can do some less surgeries. We're not, Bob, what you're going to do now is you're not necessarily going to lose every single lymph node after you've had this immunotherapy response. The second question, I think, really drives home. Yes.
Real before you,
Please.
You're talking about, do you really need a surgery next or after? Well, I met with I had my third therapy. Met with Dr. Tafaro. He looked at my tumor and he said, I think it was like I know you're a busy man, but 2 centimeters or something, And he says, well, let's do the next therapy and then we'll meet again and decide if we're going to do surgery. Which I said, that's great, because, as long as I'm moving forward in the right direction, as a team, we're working together.
I think that's the important point, the team.
Yeah.
Dr. Tafaro, when do you think we can declare that a patient is fully cured?
Well,
isn't that a deep question? I love
that is
that
a
question.
very deep
Thank
question.
you for whoever asked
I
that.
think I could get the Nobel Prize if I knew that for sure. So, actually, the truth is, I've seen people recur 5 years after they were NED, no evidence of disease. And we've seen that in melanoma before. That's why we have surveillance, active surveillance. So the protocol in most places that do, I was at Sloan Kettering, I was at Hopkins, I'm here, we follow you for 5 years, classically. After 5 years, we say you're in remission, and maybe you'll have an annual scan, a study or something. But I tell my patients, we'll become good friends. So cure is something, no evidence of disease on clinical exam or scans, or maybe now fluid biopsies or things like that, follow blood tests, which are not widely available right now. But
It's hard to define.
It's hard to define.
It's hard to define.
What is cure?
Yeah.
Will I never see this disease again?
I mean, I feel like our field has really wrestled with that question. I'll share the way I see it, because another question is, for how long do you see us, right? We have these great results. Do you see us forever? So, and for what reason are you seeing us? So I would say, the goal is to go back to being a person who hasn't had cancer. It's not like tomorrow I can't have cancer, right? It's just right now I don't. And so when you're done with treatment, right now, technically, it's that 5-year point. I actually don't know how we ever decided on 5 years. But yes, so all of us here, you'll see us for about 5 years. And after that, what I say, well, you're cured, you're done with your treatment, you're done with your monitoring. Your risk of having something happen again is about the same thing as me getting something new. So it's not that nothing will ever happen. It's just that you're back to the regular pool. Well, I'm going to end on that because I find that very positive. We're actually all here, and none of us know what tomorrow brings. Please go have a break, get some refreshments, and then we'll have more news for you in the second session. Thank you so much.
Oh, wait.
Oh,
10 minutes.
Nice seeing you.
hey, good seeing you too. Hey, hope your hand's getting better.
Oh,
Joe Cool, back in school, hanging round a water fountain playing the fool. Joe Cool, take it light. If the principal catches you, you're out of sight. Take those shades off, walking around the hall. Joe Cool, making the round, checking all the kiddies up and down. Joe Cool, play it straight. If the principal catches you, it's gonna be too late. Yeah, better learn to act now. Joe Cool, after school, working in the supermarket just like a mule. Joe Cool, do it right. And be careful of the manager, he's dynamite. Check each item, get those prices right. Joe Cool, straightening things out. Take it easy, buddy, you don't have to shout. Joe Cool, just relax. If you bug the poor old man.
Hi, everyone. We're back. Thanks for coming back. So I'm going to ask our AV team if they can flash my slides. Let's see. Can you ask them? Oh, can you start with the first, just the opening? Thank you. Just to orient what we're doing. No, like the actual title slide, thank you. Maybe we can't. Okay, well, all right. Well, I hope everyone had a good break. We're glad to have you back together. We wanted to, I'm really excited that we're having this symposium this year because it's a really unique year. We have a new FDA approval for a new treatment in melanoma. And I love that Dr. Isaacs is here with me. He's part of our cell therapy and immunotherapy unit. Dr. Isaacs, why don't you tell us a little bit more about lifileucel and tumor-infiltrating lymphocytes? What is this new treatment all about?
Yeah, so this slide kind of has a nice background of many steps that are part of this treatment. It's a very complex treatment, but we're working to create teams that can effectively provide the treatment and walk patients through that journey. The first thing about the TIL therapy is it's actually not that new of a treatment. At the National Cancer Institute in Maryland, they've been giving it for over 20 to 30 years. And the advancement that has happened now is we're learning how to, provide a complex treatment like this to a much larger group of patients all throughout the country. And that's really what the lifileucel, the Amtagvi FDA approval is significant about it, and that we can offer it here. People can have it in most states throughout the country, and that's
23 centers to be exact.
23 centers throughout the country. So that's, and it's now not on a trial. So it used to be you have to go to the DC area on a trial, and now we can do it as a standard of care. But what it involves is that the first step you can see there is that you actually have a tumor resected. And so we've talked a lot about surgery earlier this morning, and sometimes the goal of surgery is to remove all the melanoma that we see to put everything back in remission. But with the TIL therapy, our goal is even if you have multiple sites of melanoma, to just remove one of those sites. And we used to not do something like that because then you'd have melanoma other spots in the body, right? And so what would be the goal of removing just one spot? But now we can take a tumor about 1 to 3 centimeters in size. You have a surgery, and then that tumor is taken to what's called a GMP certified lab. And the significance of that is it's a very highly regulated medical grade lab, and they actually take your tumor there and expand the immune cells using medicines that are given outside your body to then grow this product.
So let me clarify here. So essentially you're saying there's a treatment that's already inside you, but we're having a way to identify tumor-infiltrating lymphocytes that are on your tumor. And thanks to surgeons like Dr. Tufaro here, you're able to harvest them.
Yeah, and it's a good question as to, if the immune cells were there before, why weren't they working, and how do we get them to work now? And a lot of our treatments, like the checkpoint inhibitors that we have been using as a standard of care treatment, they're trying to reactivate these immune cells that are in the body. Unfortunately, it doesn't always work, and so this is another approach at reactivating those immune cells. And there's a couple reasons why it could be different. The main one is that if the melanoma is still in your body, there's a lot of other factors that can prevent the immune cells from being as effective as they could be. If you take the melanoma outside the body and kind of separate it and allow really good growth conditions for these immune cells, they can grow out a lot more immune cells doing it that way than if they're giving you a medicine directly in the body.
Yeah, in fact, when the product comes back, it's anywhere from 7 to 70 billion cells
So
that are
that's
coming
a
back.
lot of cells, yeah.
When this product comes back and someone is admitted to the cell therapy unit, take us through what the experience is like.
So I think what can be challenging about this treatment is that there is a lot of excitement that it's a truly different approach than we have been doing on a standard of care basis. But it is important to review with everyone that there's a lot of intensive components of the treatment. The biggest part of that is you do require chemotherapy prior to getting the cell treatment. And the idea is that if you just got the cells back, they would kind of be lost in your bloodstream because you'd have all these other immune cells that would kind of crowd out the TIL, the cell product. So we actually give pretty intensive doses of chemotherapy over the course of a week, and you actually get the chemotherapy in the hospital. And the goal of the chemotherapy is to really completely knock down the immune, your blood cells.
So you can accept these
So you can
7 billion
accept it.
cells that are coming. That's right. For how long do you think people stay in the hospital typically?
So the chemotherapy takes about a week, and then the treatment takes a week as well. So it's about can be a 2-week hospital stay. And one of the important parts about that, though, is we're watching closely because the blood counts are low, things like anemia, risks of infection, risks of low platelets and bleeding. So it is a really important conversation with everyone that this treatment may not be the best match depending on the situation, because there are cases where we actually think that even with the 2-week hospital stay to watch things very carefully, we still might be putting you at too much risk by giving you intensive chemotherapy. We never like to put a number on things, but like one consideration is if you are above the age of 75, typically this would be a very hard treatment with chemotherapy to tolerate.
Yeah, because the chemotherapy is about similar to what you do before accepting like a bone marrow transplant, right? And even though there are regimens, that where people who are older now getting this, it is a significant risk. Right.
Yeah, and we always like to say we don't want to do any harm. And so these are challenging conversations because I have had a lot of patients ask about the treatment, and depending on the situation, considering the chemotherapy part of things, it does affect that.
That said, the other angle to see is, most patients who have melanoma these days, we don't usually give chemotherapy. So it's a different situation than someone with a blood cancer going to a bone marrow transplant who's already had, several rounds of chemo. Here, if you're a young person, your bone marrow should be robust, and then this is what we can offer you. And it's the only treatment so far where, it's one hospital admission, you're here for several weeks, and then you're finished. And so, it's 23 centers around the country because it isn't, going into the clinic every week or every 2 or 3 weeks as you've been doing with checkpoint inhibitors. It is something that you can consider, even if you live further away. So that's for someone who has spread disease. I think there's obviously other ways that we are evaluating these new cell therapies. I think one study that we're considering here, also in collaboration with Dr. Sufaro, would be to give it potentially just right after surgery. What do you think about that?
So as you saw in the last diagram we were discussing, it's a long process of having the surgery, getting the chemo, and waiting for the cells to be made, which can take several weeks, and then receiving the chemotherapy and going through the treatment. So one of the things we're finding is that right now it's approved as sort of the last, after a treatment after several different options, after standard of care treatments. And so it can be challenging to give the treatment when there's delays and waiting to get things started. So the earlier this treatment is tried, we're starting to consider may actually have better outcomes. And so
that was recently shared at ASCO, right? That interestingly, and it's Dr. Rosenberg's lab at the NIH who really pioneered this new technology, that if you give it when you've never had treatment, it looks like the response rate may be higher.
Yeah, and so there's already trials looking at if you have stage 4 melanoma, it would be the first treatment that you receive. And so those trials, we will learn more about that. This trial we're talking about now is actually moving it up even further. And the idea is if you are having a surgery for a larger stage 3 where it's in the lymph node and it's 2 or 3 centimeters, you're already having that surgery. So we could look at taking the tumor from that surgery and then making TIL from that. And so in addition to getting a checkpoint inhibitor as part of your treatment after surgery, we would also be giving the TIL therapy after surgery with the goal of reducing recurrence.
Yeah, I really like the biology behind the idea of that trial, right? Because, Bob joined us earlier, and, one reason we are giving immunotherapy prior to surgery now is to activate your immune cells that know the tumor already ahead of surgery. That's one way to do it. What if we just were able to pick them off your tumor and then make them and just give them back to you? So that'll be really interesting to see, what works out here. I think another trial that we have open here, I wanted to see if you could give us a thought, because, not all cell therapies are the same.
Yeah, so there are a couple different branches of cell therapies. So TIL is appealing because we have it as an option now, we know it works. But there are some other approaches. So one is our TCRs, which are T cell therapies that instead of going directly from the tumor, we just collect some of your blood cells. So it's called apheresis, and you just get connected to a machine, and it's like if you're donating blood, but you just donate your cells to be used as a cell therapy. And what's different about this is because they're just collected from your blood, those cells are probably not very specific for the tumor. So we don't think that just collecting the cells from your blood and giving them back would be good enough to target the tumor. So these TCR therapies put in a new T cell receptor. So there's some what's called cell engineering that occurs with these. They take your own cells and put in a new T cell receptor that we think is more likely to recognize the melanoma or any cancer, and then they're given back as a cell therapy product. They're very similar in that they take your own cells and they require chemotherapy to allow room for the cell therapy, but they're different in that we try to pick a specific target and add in a new T cell receptor. This trial that we have called T-Scan here is trying to match patients based on their tumor antigens and find personalized therapy in that way.
Yeah, different types of personalization, right? Either taking it directly from your tumor tissue itself or matching it in this way. I think this is really exciting. If you want to hear more about some of these treatment options, I hope you stay for us in the afternoon. Dr. Diwakar Dawar is here from UPMC, and he's going to tell us a little bit more about all these novel treatments that are really revolutionizing the field and also being used now. They started in melanoma, but and we have the first approved cell therapy in a solid tumor, but they will soon roll out to other patients with other cancers. And just to tell us that we are not in a silo. We're here if we want improvements to our care, we want better treatments. It takes all of us working together. Well, thank you, Dr. Isaacs. I'm so glad you could join us today. Well, to follow up on that, I'd like to invite N.P. Taylor, whom many of you hopefully know or may know. She works with us in medical oncology and sees many of you as long-term survivors. I was able to speak to some of you in the audience, and this is really something new. In fact, in melanoma was where we coined the term stage 4 survivor. And there are many things that we are still finding out together, but I love that Taylor's here to sort of guide us what to expect, when things are working well and you're living longer.
I will move this microphone way down here. Well, thank you again. My name is Taylor Kuhn. I'm a nurse practitioner. I work in the Melanoma Medical Oncology group. So I work with Dr. Truong, Dr. Isaacs, Dr. Kennedy. I may be known to some of you who are currently receiving immune therapy or have recently received it. And today I'm going to be talking on long-term survivorship after a stage 4 diagnosis. How do I click? Oh, no. All right. So what is the definition of survivorship? We'll first take a look at this with the National Cancer Institute defining survivor as that an individual is considered a cancer survivor from the time of diagnosis through the balance and challenges of his or her life. Family members, friends, and caregivers are also impacted by the survivorship experience and are therefore included in this definition. So all the patients, family members, caregivers who are here with us today and online, you guys are all in the survivorship process right now. And the primary goal of long-term survivorship is to empower patients to take ownership of their care and long-term health. This is through education, assessing needs, and ensuring that proper tools for success are in place. And why is survivorship important? Survivorship includes not just the physical, but the mental as well. It's shown that up to 75% of survivors have health deficits related to their treatments. And over 50% of cancer survivors have chronic pain and fatigue. 70% have experienced depression since diagnosis, and a third have dealt with infertility. And now we can take a look at survival rates, specifically in melanoma. In December of 2022, the Journal of the American Medical Association looked at long-term trends in melanoma mortality rates in the US between 1975 and 2019. As we can see, the mortality rates have declined significantly since 1975, with the biggest difference being between 2013 and 2017, with the approval and the implementation of immunotherapy. And on the topic of immune therapy, we'll take a look at survivorship in the setting of side effects from this systemic therapy, and for patients who have and are currently receiving immune therapy. As many of our patients know and have experienced, immune-related adverse events, or IRAEs, are prevalent and can extend far beyond the completion of treatment. And while most of these are temporary, some can be long-term, and like Dr. Kennedy had touched on, this is not a one-size-fits-all type of treatment. In 2021, the National Cancer Institute conducted a study in which researchers reviewed medical records of 387 people with advanced melanoma who were treated at 8 hospitals between the United States and Australia. And it was discovered that more than 40% of patients developed a long-term immune-related side effect. Most of these side effects did not go away during the nearly 1.5 years that patients were tracked. And overall, 167 patients, or 43%, had an immune-related side effect that lasted for at least 3 months after completing treatment with an immune checkpoint inhibitor. This is what the researchers labeled as a chronic or a long-term side effect. The vast majority, or greater than 90% of long-term side effects were categorized as mild, though they interfered with activities of daily living, quality of life, and they required treatment. So even though they were categorized as mild, they still significantly changed the way patients lived their lives prior to starting treatment. And the most common of these immune-related adverse events were adrenal insufficiency, arthritis or joint aches and pains, conjunctivitis or blurred vision, or thyroiditis or hypothyroidism with the inflammation of the thyroid, many of which our patients here today are currently managing. And when we look at what we as healthcare providers can do, referrals to respective specialties play a large role in survivorship. We're lucky to have so many specialists who are interested in the development and management of long-term IRAEs. Patient education prior, during, and after treatment remains essential, and understanding that the impact of chronic side effects on quality of life can really be highlighted when we specifically ask about them during our patient visits. And I will just talk a little bit about the pharmacovigilance clinic at Taussig. I know Dr. Kennedy touched on this, but this was created in September of 2023. It's half a day each week on Friday afternoons. And it was created because with the increasing approval of new immune checkpoint inhibitors, the need for referrals for IRAE diagnosis and management is also increasing. Many of these IRAEs involve multiple systems, so a multidisciplinary clinic approach allows timely access for evaluation by the appropriate subspecialists. And in long-term survivorship, it can provide longitudinal care for chronic IRAEs. And I included the same picture with Dr. Kennedy and the other physicians at the PV clinic. And some of the specialists that she highlighted, we have like rheumatology, pulmonology, endocrinology. We were having gastroenterology, cardiology, dermatology, so lots more, and basically all of the ologies. And additionally, preventative care should be emphasized in long-term survivorship, and this still remains really important after a stage 4 diagnosis. Primary care is the first line of defense in healthcare. It's encouraged for patients to continue to see their primary care provider during and after treatment. PCPs perform wellness exams, they provide anticipatory guidance, they help with medication management and conduct screenings for chronic diseases such as diabetes and coronary artery disease through your A1C and your cholesterol. And all of these are really important for long-term health and quality of life as well. And additional cancer screenings that are recommended to the general public are also recommended and encouraged for patients with a stage 4 diagnosis. It's just as important to treat the existing cancer as it is to prevent any other cancers. So we can see all the different guidelines that we have for things like skin cancer, breast cancer, cervical, prostate, colon, oral, and lung cancer for those at higher risk. And then another important aspect of survivorship is assessing what life is like after cancer diagnosis and ensuring that those proper tools for success are in place. Education promotes patient empowerment and confidence, and research has shown that people who feel more in control not only feel better, but they function better in their day-to-day lives. Developing a new normal and new expectations is a challenge after such a life-changing diagnosis. In focusing on what is modifiable, such as like diet, exercise, this can provide that sense of control. The National Comprehensive Cancer Network also publishes melanoma-specific patient education each year, which is a great resource for patients and the care team and can be found on their website. And there are also more interactive ways of providing education for our patients. Something that we did have and that we're working on bringing back to our department are shared medical appointments, or SMAs. Some of you may have been involved in one of these in the past, but this is a 90-minute appointment with a provider and a facilitator. It's with 10 to 12 patients with a similar condition or a chronic disease who are seen in sequence. And it combines the traditional one-on-one provider visit with participation in a shared discussion. And when we look at the benefits from a provider and a patient perspective, there are a lot. For the provider, there's improved access to patients. We can leverage more resources. It improves workflow efficiency, and it removes redundancy. For patients, there's access to additional learning resources. They have increased time with their care team, and there's opportunity to meet other patients undergoing similar treatments and experiences similar to what we're doing today. And advocacy and support are beneficial in long-term survivorship, and they provide a sense of community for patients. There are a growing number of organizations for cancer survivors, And these are just some of the organizations that are focused on melanoma, such as AIM at Melanoma. They're each specific to a unique mission, and these organizations can be found on the NCCN website, and is also a great resource for our patients and our care team as well. The Taussig Cancer Institute also has survivorship-specific resources, which I think we're going to hear a little bit more about soon, but I'll touch on some of them with the Fourth Angel Mentoring Program. This is where caregivers are matched with trained volunteers based on similar age and cancer experiences, and this provides empowerment for patients. They provide knowledge, awareness, and hope. Art and music therapy, meditation, and Reiki, those all focus on engagement and self-expression, both of which have shown to improve mental health overall. In understanding that a cancer diagnosis not only impacts the patient, but those around them, we have care partner services available as well. And again, just highlighting some great melanoma advocacy and support groups that are available to our patients. And all in all, the key takeaways, there's a growing number of survivors each year, and we expect to see that trend continue through the development of new treatments and best practices, such as the ones we just heard from Dr. Truong and Dr. Isaacs. Education encourages patient empowerment, and it provides the tools for success. Close collaboration with other team members, specialties, patients, and caregivers optimizes quality of care. And most important of all, long-term survivorship is holistic and places an emphasis on the fact that treatment extends far beyond the disease. These are my references, and thank you all for allowing me to talk today.
Thank you, NP Kun. Thank you, NP Kun. That was great. I'm actually going to take you through our wellness resources. Unfortunately, Bria was not able to join us today, so I'll share the information on her behalf. Could we pull up the title slide, please, for the wellness talk? Thank you. Wonderful. So, yeah, we're really proud to offer these resources here at Taussig Cancer Center. It's just like Taylor said, you're a survivor from the day you come through our doors, and we want you to do well from the beginning. She touched on some of these programs. Art therapy here, it's really an opportunity for self-expression, can reduce anxiety and stress. Here in Cleveland, we have many art programs actually outside of our institution, and so we have great volunteers who participate here to get our community engaged. They're led by a board-certified art therapist and can include a variety of media, drawing, painting, collage, and you don't need any experience. It's really just there as a different way to sort of process your journey. You can do individual sessions, or there are even open art studio hours. We'll share these slides with you later, and there's actually rack cards also on your way out that you can pick up. And you can make use of this at any time in your journey, while you're going through treatment, afterwards. And so Lisa Shea is your contact there. How not to focus on music in Cleveland here. This is something is very special to me. It's beautiful, it decreases your anxiety, a different type of opportunity for self-expression through so many modalities. Yeah, it is a very positive coping skills, either music together or music alone. There are board-certified music therapists here as well. And sessions can include exactly that, listening or making your own music, singing. Everyone, your whole family, all your friends are encouraged to join in. And again, music experience is not necessary. I'm not the best singer, but I love doing it. So yeah, and these are available even when you're getting infusions. So again, it can be during active treatment, it can be later, whenever you stop by, we'll be glad to see you. I love that we have this, and I think I'm told this has to do with some of our hospitality services in town that come and offer this, and we have a high tea. There's music, tea, pastries. It's from our volunteer service. I like because it helps people connect with others who are going through treatment or coming to Taussig for any reason. It's at a high tea time, 1:30 to 2:30. It's on our first floor lobby. There's a piano out there. And it's once a month on the fourth Wednesday. And yeah, it's donated by Chefs for Hire and open to anyone who's coming with you. So I tried to sneak down for that. And mindfulness and yoga, so important for any of us, going through treatment or not actually, can enhance quality of life, decrease stress and anxiety in a different way, very self-directed. We have certified yoga instructors. There are classes Tuesday and Thursdays. And in fact, now that I'm saying it out loud, they also come and work with your caregivers. I want you to know that. So on the 5th and 6th floors of the Taussig Cancer Building is where your doctors are, and there are also yoga sessions for us. This is the 5th floor, and they have also virtual classes, which is great, and the contact here is Kim Mazzoni from our cancer center. NP Burke talked about, going through surgery and healing from that. There's many different reasons why as you're going through your cancer journey, during or afterwards, that you might have pain or discomfort, maybe less mobility, and massage can be a great way to improve those symptoms. We have licensed massage therapists who work with us, and this is their contact. The overall program is called Reflections Wellness Program, and Reiki is part of this. I especially like the skincare offering that's part of this program, which I thought was really unique. Especially having a type of skin cancer, you can see, our treatments can alter skin color and texture, either because of a rash, or some of you may have experienced vitiligo while you're on immunotherapy, or even some other acne rash, right, with the targeted therapies. And so there's also many reasons. And sometimes, I'm a vain person. I don't like looking at myself in this way. So this is a great resource, safe restorative treatments. They work together with your providers to make sure that it's in line with the medicines you're getting, but that you're still getting a good cosmetic outcome, and the individualized consultations. It even includes makeup application for the women in this room. So I thought that was really cool. This is the Fourth Angel mentoring program that Taylor mentioned, and AIM at Melanoma has a buddy system. We all know that to get through all of this, you need a friend. You want to have an additional set of ears, and it's so great to have it be somebody who's been experiencing through a similar journey. So we have program staff that facilitates finding you someone that matches with you by whatever you feel is important. And they help you make a contact. And I have to say, there's really only so many things you want to hear from us in the office. Your life is out there, and having someone who's gone through this and has found a good spot. And in fact, while I'm here, I'll have a shout out. If any of you want to take on a mentee, we would be grateful. Share your stories, share your experience. We're really glad that we have these resources. And there's actually more. I only picked a couple of the resources I feel apply the most. There's a resource center at the bottom floor of Taussig. It's very central. It's actually right next to that piano as you enter. And so stop by and see, what else might be there. Thanks, everyone. It's time for another panel for us. We have two patients. These are people, I'm so glad that this is another spectrum of survivorship. I said, we have stage 4 survivors. So I'd like to ask you all to come down, join us up front. Dr. Kennedy, Dr. Isaacs, Taylor, and Emily, if you could come down and sit with us. And thank you for sending questions. Some of those that we didn't get to before, we'll get to now.
Want me to sit right here? Okay. I'll sit right here.
Sure. No, just tell me how you introduce yourself.
That's good.
You won't remember me, but I remember him. So, good morning.
Okay, so next we have our patient panel. So we have two of my patients actually. Thank you both so much for joining us today. So I'll introduce them to you and then we'll ask them to share a little bit about their stories. I know they've both been thinking a lot about what they want to say, so thank you for your thoughtfulness. So first we have Jen Frederick. She is one of my patients. And then next to her we have Jerry August, another one of my patients. It's been a real privilege to care for both of you, and thank you for joining today. So why don't we start with Jen, just have us tell you a little bit about yourself and your diagnosis, and kind of what your journey's been like.
Okay. So my name is Jen Frederick. I'm 50 years old. Sorry. Okay. He might have to go first. I'm sorry, I just get real emotional. No, I could do it. I could do it. I'm good. I could do this. Sorry. So, I noticed I thought that they were cysts in my groin area and then one on my inner thigh. And I didn't think anything of it for months. So I just let them go. And in time, it got bigger and darker. So I told my husband, I said, something isn't right. And then I started to get scared. But I had a hysterectomy scheduled. So I decided to see a general surgeon in regards to these cysts that I thought. And he was able to talk to my gynecologist, and I was able to have 2 surgeries at one time. So they were removed, and when they were removed, obviously they were lymph nodes. The general surgeon said to my husband, "Did she ever have varicose veins worked on or something?" And no, I never did, because they were black. The cyst was all black, and it looked like it was a ball of just black veins. So I get out of surgery. Never did I think cancer was even a thought. It wasn't even a thought. I recovered from my hysterectomy. It took a week. I'm driving, my mom's driving me to my follow-up appointment for my hysterectomy. And I look at my phone and it comes across on my chart that I had metastatic melanoma. And I thought to myself, wait, what? I didn't even understand, because again, I didn't even think it was even possible for me to have that. So fast forward, I was diagnosed December 20th. December 29th is when I met, I call her my angel, Dr. Kennedy. And I was just ready to take on this battle, whatever I needed to do. But I'm gonna back up just a little bit. I did get PET scans before I did come to see her. I was fortunate enough to be able to have that done, and I did find out that it did go to my lungs, but at this point, I did not know that it went to my brain. So I had that done before I went to see Dr. Kennedy, and when I met her on December 29th, I walked in there and I knew that I was in such good hands just by talking to her, maybe for 5 minutes. So we came up, she did tell me, she's like, I think I wanna get you an MRI done because melanoma loves the lungs and the brain. Well, luckily, I had that done. So that's how I found out that it also went to my brain, and I thought, oh my gosh, my life's over. Like, this is it for me. I can't believe, at that time I was 49, but I'm like, I just didn't understand at my age how this can really possibly happen. I never had any symptoms. I was completely asymptomatic. I never felt sick. I never was, nothing. I felt like a normal, in shape, healthy young woman ready to still live my life. And yeah, so then that's when I met her and I said, I don't care what I have to do. Just give me the best treatment I possibly can get. I want to be as aggressive as I can be. Just keep me alive. And she did. So we started treatment, and here I am. So I did, I completed 3 of the 4 Opdivo and Yervoy. I pushed myself through that ended up with horrible side effects. Ended up in the hospital, but never once did I give up. I just fought and fought and fought. I had colitis so bad. I think I had every single side effect possible. But I don't even care because I'm here. But I fought through. I ended up, I didn't have treatment for like 3 months, which is fine because I had to recover from having colitis and all this inflammation. But I was able to start back up, and now I'm just on Opdivo, and I'm in my 3rd treatment, and I'm doing fantastic. I feel bad sometimes because people look at me and they're like, "You have cancer?" And I'm like, "I do. I do." It's amazing what immunotherapy, what an amazing care team I have at the clinic here. My care team's amazing. My husband, my family. I'm sorry, I'm so emotional. It's just to hear all these stories, but I couldn't be more thankful for my team, my doctor, and the Cleveland Clinic. It's just, they're amazing, so thank you. So yeah, so I'm just gonna continue getting treatment. I am gonna fight as hard as I can, and if I can be an inspiration to anyone, anybody can get through this. They can. So, sorry. It's all yours. I hope you don't cry like I did.
I don't count on it.
Okay.
Well, good morning. My name's Jerry August. I'm 75, and good morning. And I was asked to share my story. And let's see. So, I'm here for several reasons that I'm able to do this, and not necessarily in this order, but God has shown me much grace through this journey. Fortunately for the miracle of medicine and the oncology department here, and certainly for my, my advocate. My story started on March 11th in 2022 at my family doctor's office. I hadn't felt right, was fatigued. So I went to him, we shared a little bit about what I'd been doing, and he suspected maybe I had carbon monoxide poisoning, and something that he didn't have a blood test to do in his office. So he sent me to the ER to have the blood work done, and I found out later a complete workup. So in the ER room, the ER doctor came back and said, "Well, I have things that you probably don't want to hear. You have cancer." achy. So you have cancer, you have a lung tumor, and you have 3 brain tumors. So I was admitted, they did a biopsy of the lung tumor, and by the way, this was not at the Cleveland Clinic or one of their affiliates, this was somewhere else. They did a biopsy of the lung tumor and came back and told me I had non-small cell lung cancer. So we immediately told them that we wanted a second opinion and certainly wanted it here because of the gamma knife that they have. So we came up here, met Dr. Pinnell, and he prescribed that we have a chemo treatment and an immunotherapy because of the non-small cell. I had each of those on the same day. About 3 or 4 days later, was really sick. And was back to the hospital I came. And while here, they did some other tests and found out that I had 2 tumors in my abdomen. So we had surgery to remove the 2 tumors and 14 inches of my small intestine. They biopsied those. And told me that I had melanoma. So we met Dr. Kennedy because she does melanoma and Dr. Pinnell does not. So it was puzzling that I have 2 types of cancer. So Dr. Kennedy requested the actual biopsy tissue. From the other facility, and they determined that it was melanoma also. So I'm probably one of the few that are happy with a melanoma diagnosis. At least it has a better success rate of the better prognosis than non-small cell does. So Dr. Kennedy prescribed immunotherapy, 24 months at 4 weeks intervals. And after about 3 months of treatments, the side effects kicked in. I lost 70 pounds during that adventure. We stopped immunotherapy for a couple of months while we treated the symptoms. I finished my treatment. It would have been easier to read it. So I finished the treatment a month and a half ago. The 3 brain tumors and the several lesions were treated with 2 gamma knife treatments shortly after seeing Dr. Pinnell. The 2 abdominal tumors were removed, and I've gained 70 pounds back. And a week and a half ago, Dr. Kennedy, along with the radiologist, seemed to think that the lung tumor has died. It still lights up on a PET scan, but they believe that it might be dead. So I have a couple suggestions that I'd want to share that might help you. First of all, you should have an advocate that goes with you, somebody that goes to your doctor's appointments. A second set of ears is certainly helpful. The visits with your oncologist and the care team have a lot of information that you won't remember, and your advocate can take notes and does. It's also helpful if you have a village. Let them help you. They'll ask you to help. Give them jobs to do, or at least ask them to pray for you. My advocate, I've been blessed to have my wife. Through this, and her 3.5 notebooks full of notes. I would encourage you to keep up your attitude. Immunotherapy is not a sprint, it's a marathon. And you had no control of getting melanoma, and you won't have any control on how your body reacts to the treatments. So don't get discouraged, don't give up. And certainly don't lose hope. And lastly, show appreciation. And gratitude to your caregivers. I know they're doing their job, but they don't make you feel like it. Some heroes wear a cape. My heroes wear a smock. A smock and a stethoscope. So, thank you.
Thank you very much, Jerry and Jennifer. Both really inspire us. If okay with you, because you've really sent us off with so much grace and meaning. I would love our audience to get to write some of the questions to you. One question is, both of you made treatment choices at the time, and like you're saying, it's like this fog. You feel very sick. What do you feel helped you make the choice? What got you through that initial really difficult time?
Well, I can say for me, I didn't think of it as I had cancer. I just kept saying to myself, I'm just really, really sick, and it's going to be over soon. And I just kept promising myself, like, just stay positive. You have so much to live for. This isn't the end. I never let the word cancer enter my vocabulary. I didn't even make it an option. I mean, I have an amazing family, an amazing husband, and I just had a lot of life to live, and I just kept saying to myself, I'm never giving up. So I guess I can just say I never wanted to think I ever had cancer, so that's just how I lived. This isn't cancer. So that's how I got through it.
I might be a little more practical. We spend a lot of money at professionals, whether they're doctors or CPAs or attorneys. And so since we spend a lot of money doing that, you have to have confidence in the advice that it gives you. Dr. Kennedy recommended a treatment plan. And therefore, my attitude was much like Jen's. I won't give up, and I will do what she told me to. So I have white coat syndrome when I see them. But I was confident that what she prescribed was going to work, and didn't lose hope.
Yeah, trusting your care team. I mean, I immediately trusted Dr. Kennedy. Anything she said, I believed and I trusted. I didn't even question it. I said, I basically was just like, do whatever you think and do it with a vengeance, because I'm ready to beat this. So you really do have to trust your care team, and I put my life with her any day of the week, so.
Well, speaking of Dr. Kennedy, we have a question in the audience, and I feel it relates to both of your experience from what I'm hearing too. So I'll read this if that's okay. It says, I was started on Nivo for cutaneous melanoma, the stage of which was determined to be possible 3A. But most said 1B due to uncertainty of what it was. After 3 cycles of the Nivo, I developed erythema nodosum and pneumonitis. So this friend out here had a side effect. I had 4 weeks of prednisone only and have been good since then. If frank metastasis shows up, would it be possible to re-challenge with Nivo? I'm 31 years old.
This is a great question. I think for melanoma, like the way that I think about it, I think we do this in oncology. We talk a lot about risk and we talk a lot about benefit. And we know that the benefit of immune therapy in melanoma is potentially really, really high. And we know that even people with stage 4 melanoma, immune therapy can work for a very, very long time. And so because the benefit is so great, that makes me very reluctant to tell someone that because of risk, I can't offer them immune therapy. So there are situations like this where you've previously had a side effect from immune therapy. Say that in the future, say that treatment has to be stopped, but then in the future, there's a question of like, your melanomas come back, we want to give you immune therapy again. I would say generally speaking, what I'll do is I'll work with the physician. So in your case, like working with a physician who treats your erythema nodosum, trying to make sure that's under as good of a control as possible and kind of all working together to come up with the safest treatment plan. As a general rule, we actually see a lot of patients who have had side effects to immune therapy where we've then treated the side effect and given immune therapy later. Actually, both of you two are an example. Between the two of you, you've had at least 4 or 5 or 6 different IREs, and afterwards, serious ones, like requiring hospitalization. And we were able to give immune therapy after, and we know that's a risk. We know there's a risk that side effects could come back if we give you immune therapy again, but we also know that the benefit is so high that a lot of times we will find a way, to do it as safely as we possibly can.
And I can say that after or starting back up with my immune therapy, I've had 3 treatments, knock on, we'll pretend this is wood. I have not, the only side effect I've had was fatigue. And I'm like, oh my goodness, like I can eat again. So, fatigue has been my only one. So I've been fortunate for that. Yeah.
I have a question for NP Kuhn. Because you're seeing many patients like Jennifer, like Jerry, they are now finished with treatment. What have you noticed in terms of scans for how long people do it? Do people want to do them a lot? Are people okay with 1 year, 6 months? What have you seen?
I feel like that I see a really mixed picture of how people feel about being, quote, graduated from our care team. Some people are okay with never really coming back to Taussig and seeing us, but some people do want to be like lifelong patients and get scanned every so often. Some patients want to just come in and see the provider or the doctor again, and even if that's not including scans, it's kind of just having that extra layer of protection and having a physical exam, maybe labs done. So it's definitely a mix of people, but I'd say majority of people do like to stay with the care team for a while.
Thank you. Our final question I have here, I want to direct both to Emily Chang here and Dr. Isaacs from both your points of view. And I hope it's okay because this question was signed. So this is from Philip Kinson. It says, many of the treatments and observations of benefits and failures are more or less single observations. I'll give you that. Is anyone using computers to analyze multiple observations into understanding treatment options and perhaps using multiple drugs? And I guess I'll expound on that. Maybe even our outcomes with it, who has side effects, who doesn't. I was hoping Emily from your, Cleveland Clinic enterprise viewpoint as our pharmacist, and then Dr. Isaacs from his research experience, whether both of you could comment on that. Thank you.
Yeah, so in terms of assessing outcomes, adding on to multiple treatment options, I know there's investigational trials that are looking at combining multiple therapies. They're looking at investigational trials of new therapies. So I guess it's a little bit hard to say just because the oral agents that we do use, so sometimes can have overlapping side effects. So sometimes it can be difficult and challenging to see what toxicity is associated to what. So a lot of the times we kind of just think about like, okay, if we hold this treatment, does the toxicity improve? If it doesn't, should we hold the other treatment option and then go from there? So really, a lot of it is overlapping side effects. So I think we just need more information on what's being reported.
Yeah, and I think it's a really good question about sort of the future of care. And I would agree with some of the sentiments in the question that we do use a lot of the medicines that we use now, we kind of broadly recommend, but I would say the reason for that is they do have outstanding results for many people. And so for one part, I think the medicines we have, we're very happy that we can achieve these outcomes, but it is a good point that I think in the future, we will want to be more personalized with some of the treatments. And the thing is that the immune system in the body is far more complex than we truly understand and appreciate now. So perhaps things like artificial intelligence and some of these computer models will allow us to take the next step in understanding that. So I think we're very early on in that time period. So it of course will be very exciting over the next 5 to 10 years to see where treatment is going.
So on a slightly different note, we have one final question from the audience that I think is a really nice way to conclude the session. So this is for Jen and Jerry. What advice would you give to caregivers about what's the most helpful?
Do you want to go?
What's the most helpful for the patient or the caregiver or the advocate?
That's a great nuance. Why don't you answer both of those? Yes.
It's extremely encouraging for the patient to have somebody there with you at every visit, every treatment, every test result, because the information isn't always pleasant. And I can't emphasize enough on the note-taking of the advocate. 3.5 notebooks over 2.5 years is a lot of stuff. And particularly the last notebook is only half full, and it's been since sometime early in 23. So the first year, there were a lot of notes. And it's encouraging to have that advocate with you, and which also will include a village to help you through that. For the advocate, I can't tell you how important it is to take notes. If you spend a half an hour with your doctor, there's more information than you're going to remember.
So I do agree with everything Jerry said, but I will tell you for me, I never hesitated, whether if it was 4 times a day, to make sure you're communicating with your doctor any sort of side effect and to get ahead of that, so you can be treated accordingly, but also to having a second set of ears outside of your caregiver at every single appointment, because there is a lot of times that you do miss things, which is really important to make sure everything is covered. And then you can go back and you can read and educate yourself, because I know I did that a lot. Two more things. Definitely, it does take a village, and you can't forget about your caregiver, because your caregiver also goes through a lot more than we probably know as the patient. So I always had to remind myself that, my caregiver, who's my husband, he was going through it just as much as I was. So they can't be forgotten either. I forget what was the last thing I was going to say, but, honestly, your attitude and your positivity is everything. If you wake up every day thinking like, oh, this is just gonna be a horrible day because, I have the C word, that's not gonna help you. I mean, you just sometimes just have to fight through it and know that everything will be okay. That's how I wake up every day. And I try to tell my husband, it's going to be okay, we're gonna get through this. So positivity is always something that can't go wrong with that. So I encourage everybody in here, whether you're a caretaker or you are a patient, to wake up every day saying something you're thankful for and just make it the best day, because you just never know. So.
Well, I don't know how better to close the session than that. Thank you so much. We all have our matching orders.
Yes, we do. Yes.
All right.
You did.
Her fault.
Sorry.
Your fault. You're welcome.
Well, Sam.
Wow, yes. Thank you. I just want to say thank you for everybody for sharing your story. It really makes my job worthwhile. I mean, I'm going to get a little, sappy here. Even just hearing, whether it's at the table or out in the hallways, it is incredibly moving and powerful, I think, to hear from other people, which kind of leads into what we're going to discuss. Part of the community is not just individuals who are going through treatment, but it also helps, I think, the caregivers, our industry partners, individuals such as myself, to wake up each morning and feel as if we are connected to each other and we have a common goal and interest in ending this disease in our lifetime. So I am incredibly grateful. I just want to say personally for all of you for sharing your story. I know how difficult, I can only imagine how difficult it is. So thank you so much for that.
I mean, I think it's something we all know about AIM. I mean, AIM grew out of what your family went through. So, with your sister and your loss. And so I think for all of us who are here, it's incredibly inspiring. Exactly like Jennifer said, that with everything that is going on, there's always hope and positivity, and something that we can do together. I feel over the years, AIM has really evolved. And in fact, you've tasked us with so many more things that we can do together. I was hoping you could take us through some of that we can do together as a community.
So I think I'll mention a little bit of the history in order to answer your question.
Yeah.
I came into melanoma not by choice. So I actually had a melanoma myself when I was in my mid-20s. I'm like, this is nothing, right? Let's just have it cut out and move on. And then a couple of years later, my sister, who was 25, was diagnosed with stage 4 melanoma. And the progress at that time, she had 9 months. And there were few, if any, resources out there. There was only one treatment option, very little community. And so out of that, we needed a way
This was the early 2000s,
yeah,
right?
That's 2003. And So what we wanted to do, my family, this foundation was started by my mother, was to make sure that no one went through what we went through in the way of community, lack of treatment options, the lack of research. And so what my mother did was something that not everyone does, but it was her way of making sure that we addressed all of these unmet needs. And everybody has their own way of doing it. My mother went in full 130%, even, got me involved clearly. And so our way of giving back to the community and why hearing these stories is so important is, well, for research, I'll start there. We have opened multiple fresh frozen primary tissue banks, and we are collecting tissue here in the US and outside. We'll be starting soon so that we can offer this to researchers. We have a very comprehensive website here in the US. We actually have multiple. We have one for AIM at Melanoma for patients and caregivers and the general public on all various aspects of education. You heard earlier about our one for healthcare providers. Again, that's education. We have a Peer Connect program where we match veterans with newly diagnosed. We have also I should go back to the medical, we have a physician assistant that we have that answers questions to help address the psychosocial aspect of the disease and some of the issues that we hear. We have a podcast series that Dr. Truong helped us get off the ground. And our resources are international. We're in Europe, Latin America, Australia, and Canada, and those are translated and acculturated because I said earlier, this is a disease that's global, that we're all impacted by. We're very fortunate here in the US to have lots of treatment options and lots of resources, so we have brought those overseas. But that's only just one way to give back. We have people who run our Steps Against Melanoma walks. We talk about communities reaching out to other people. And I know lots of people do these sorts of things, but the one I'm most familiar with is Steps. And so it's a community where we, meet other people who are unfortunately in similar situations and want to support others, to have a community, to raise money for research. That's how some people give back. Some people give back by being a mentor, right? And supporting other people. So that's some of the ways that we are doing it. But again, everybody has their own way of doing it, and every single way is important.
We want everyone to feel supported as they go through their journey. Well, thank you very much for coming here today or joining us via live stream. If there are people who couldn't be here with you today that you feel this information would be helpful to, you can let us know. And this entire session was recorded, and we will share that. And we have our own resource here at the Cleveland Clinic. We share resources together with AIM at Melanoma. For any of the questions that we didn't get to today, we will, if you had signed your name, we will email you and get you the answers to your questions. Thank you so much.
Thank you, everyone.
And so important, lunch is waiting. We hope if you'll come out and hang out with us, have lunch. And like I said, Dr. Diwa Kardawa from UPMC, Dr. Kim Margolin all the way from Los Angeles will be taking our next sessions to talk about brain metastases and our next and newest treatments. So you're very welcome to come back and hang out with us for the rest of the afternoon. Otherwise, have a great rest of the weekend.
Thank you, everyone.